Okay, good afternoon. Welcome to the Committee on Health and Human Services on Wednesday, May 28th. Welcome to all of us here. Secretary, would you please call roll?
Assembly members Dahlia. Here. Edgeworth. Present. Gonzalez. Here. Goulding. Here. Gray. Here. Hathan. Here. Hibbets. Here. Hunt. Here. Jackson. Here. Koenig. Here. Nadeem. Nguyen. Here. Orntlicker. And Chair Brown May.
Here. Thank you so much. Okay, let's start with some of our housekeeping items. Thank you. Would you please mark Assemblymember Orntlicker present when he arrives, or absent excuse if he doesn't make it? Okay, housekeeping reminders. Please reminder to silence your electronic devices, please. If you wish to testify, sign in at the table. As always, when testifying, make sure you turn on your microphone, clearly state and spell your name for the record. We do have a sign if you forget your name. Members of the public may always provide testimony by calling in. The telephone number is 669-900-6833, and our meeting ID today is 862-907-54736, and then hit the pound sign. That number is available also on our agenda, which is posted on Nellis. All of our committee agenda information is posted on Nellis. We do have our third update, the third revision, which shows you the order of bills that we're planning to work today. Public comment will be taken today at the end of our meeting. And please remember to be courteous and respectful, even if we may not agree with another's position. Okay, to give you the lay of the land for today, we do have 9 bills on the agenda today. And our plan is to hear the bills and then potentially go into work session if there is no conflicts that we need to work out at the end of today. As we're at that time of session, we're going to move quickly so members know that this is what you're expecting today. We will also have members in and out as they are presenting in other areas. It's my understanding the other house just went in, and most of our bill presentations today are from the other house. So we're going to pivot. Like while we have our agenda posted, we are going to pivot today. So, one moment. Okay, so we are in order, and we will start seeing our presenter here for Senate Bill 312. So we're going to go ahead and open the hearing for Senate Bill 312. You're welcome to take the table. For all of our presenters today, I'm going to ask you to please be brief and concise, as we do have 9 bills on the agenda, and we are going to floor this afternoon at 4. So we want to get through as much as we can today, if at all possible. Thank you. Welcome to the table. You may begin when you're ready.
Thank you, Chair Brown May, members of the committee. Brett Scolari with Strategies 360. I'm here on behalf of the Reno Sparks Indian Colony. With me today is Daryl Gardapi, Chairman of the Reno Sparks Indian Colony, and Angie Wilson, Director of the Reno Sparks Tribal Health Clinic. I'll give a very brief overview of SB 312, and before I do that, just wanted to mention this was work of the Joint Interim Health and Human Services Committee. A lot of work went into this, and we sincerely thank you all, Senator Donate and everyone's leadership on this. Section 1 authorizes presumptive eligibility for Medicaid for tribal members with DHHS supplying support, resources, and technical assistance to the tribes. Section 5 creates the Tribal Health Authority Council and establishes the membership of the council. Section 6 sets forth the operations of the council. Section 7 authorizes the director of HHS to appoint a coordinator of the council. Section 8 sets forth the duties of the council. Section 1.5 authorizes 2 BDRs for the council for measures related to its scope. Section 9 establishes the account for tribal health in the state general fund and specifies that HHS will administer the account and use the funds to support the council's activities. Section 11 sets forth the collaboration between HHS and the council to develop a proposal for reinvesting federal funds from Medicaid. And Section 13 sets forth the effective dates. So I used my very brief overview. With that, I'll turn it over to Ms. Wilson, and she's going to give a few brief remarks on why this is so important to the tribes in the state of Nevada. Thank you.
Good afternoon. Angie Wilson, Director for the Reno-Sparks Tribal Health Center. For the record, thank you so much for allowing me to be here. Senate Bill 312 marks a monumental step forward in addressing the healthcare challenges faced by the Nevada tribal communities. By establishing the Tribal Health Authority Council, this legislation underscores the commitment to empowering Nevada tribes to further strengthen the tribal healthcare delivery systems serving our tribal communities. For far too long, our tribal communities have faced disparities in health services, access, and outcomes. This bill is not just a piece of legislation, it's a historic symbol of progress and partnership. By creating the Tribal Health Authority Council, the bill provides a platform for Nevada tribes to have a direct voice in healthcare decisions, ensuring that policies and initiatives align with our unique cultural and community needs. This bill is groundbreaking because it not only addresses immediate healthcare concerns, but it also facilitates a collaborative effort to design sustainable and innovative healthcare systems tailored to Nevada's tribal health communities. Our tribal communities face some of the most severe health disparities in the United States, including higher rates of diabetes, heart disease, and substance abuse. Senate Bill 312 aims to combat these issues, as the Tribal Health Authority Council will play a pivotal role in identifying gaps in services and implementing strategies to close them. This bill is particularly critical in Nevada, where many tribal communities are geographically isolated and lack access to specialty care. By leveraging the council's expertise, the state can work towards building resources that reach even the most remote areas, ensuring that no member of these communities is left behind. Our tribal nations have long advocated for sovereignty and self-determination, including the right to govern our own healthcare systems. This bill honors that call by recognizing tribal expertise and granting collaboration and authority to shape healthcare policies that directly impact our Native people. In addition, allows our tribes the ability of presumptive eligibility of Medicaid, a critical initiative for our tribal communities. By fostering collaboration amongst our Nevada tribes, state agencies, and other stakeholders, the council ensures that the healthcare initiatives are developed with cultural competence and a deep understanding of the challenges faced by our Native people. This could not be more important than now, as anticipated changes at the federal level will require federal expertise or tribal expertise in the understanding and implementation of such mandates at the state level. Senate Bill 312 is more than a legislative milestone. It represents a vision for the future, one where our tribal communities have improved resources, autonomy, and support to meet the needs and thrive. In conclusion, Senate Bill 312 and the establishment of the Tribal Health Authority Council is a historic step in addressing healthcare disparities and recognizing the importance of culturally appropriate services and collaboration. This legislation not only paves the way for a healthier future, but serves as a reminder that progress is possible when governments and tribes work together towards a common goal. This time here with you all, each of you here today, listening to this testimony will forever be remembered as a significant milestone for the Nevada tribes and our tribal health clinics. So we just want to thank you for your contributions in making Senate Bill 312 a reality. Thank you so much.
Good afternoon, the committee. I'd like to, my name is Daryl Gardipe, D-A-R-Y-L, G-A-R-D-I-P-E, Chairman of the Reno-Sparks Indian Colony. And I'd like to thank you for your consideration on passing this historic bill. Thank you.
We can entertain any questions. Thank you, Chair.
Thank you for the presentation. I do know that we do have a couple. We'll start with Assemblymember Gonzalez.
Thank you so much, and thank you so much for being here and for this presentation. I'm a firm believer those closest to the problem are closest to the solution, and so, I met with you all in January, I think it was, and so I really appreciate the work that is being done on this bill. I was wondering, do you guys get BDRs now? And if you don't, kind of how does that, how do you bring issues that are specific to your community to the legislature with or without having access to BDRs now?
Angie Wilson for the record. Thank you for the question. Quite honestly, I will say that we were asked by the Joint Interim Committee on Health and Human Services to do a presentation on tribal health care. And it was the first time in the state's opportunity to ask for such a presentation. And that actually is what led us to this point here today. I think that the tribes look at our state as partnerships. And if you're not aware, the state does receive 100% federal medical assistant percentage reimbursement for American Indians and Alaska Natives who are Medicaid eligible beneficiaries. And I think that, we've not had the BDR process, so I think that it's new to us. This whole process is very foreign to me. Usually I'm taking things forward to tribal leadership. But we're very excited for the opportunity to look at how we can leverage resources in a way that not only supports our tribal nations, but also helps to ensure and support the tribal budget, the state budget as much as possible.
Thank you so much. I appreciate that. And then I was also curious because I do know that there are a number of tribes in our state. So how does that work in terms of getting to BDRs? Like, do you foresee working groups throughout the state? I know that we have a lot of like northern versus southern divide on issues too. So I was just curious kind of how that would all just look with getting the opportunity to have 2 BDRs. And again, I'm very supportive and I really appreciate the work that's been done. And you have a great mentor to teach you how to get you through the BDR process.
Thank you. Angie Wilson for the record. That's a great question. We have a network of tribal health directors throughout the state. We're really united on the initiatives that come with tribal health care initiatives and needs in our tribal communities. We don't really see it as a north and south issue. I think that the majority of us who would serve on the Tribal Health Authority Council are really in step with the key issues happening in our tribal communities, a lot of which centers around access to quality health care initiatives, and those would be proposed by the group of the council, which are pretty unified in our stance. Thank you.
Okay, next question from Assemblymember Gray.
Thank you, Madam Chair. Good policy, but I do have one sticking point. So the legislature right now, the Assembly, we're looking at reducing the number of BDR allocations that members get. And right now with counties only get one BDR. Do you think 2 BDRs would absolutely be necessary, or would one be okay and then do like the counties do or other agencies, work with a legislator to get a BDR in? I mean, I know I always have extras up until the very last days and others do, but is that something you guys would be amenable to?
Angie Wilson for the record. I'm not sure how long counties have had just the one BDR. I don't think the tribes have ever had initiatives to have any BDRs. I think we'd be amendable to it for sure. So I think we're willing to work with any accomplishment to get this passed. Yeah, thank you.
Thank you. Members, any other questions? Okay, seeing none, thank you for the presentation. We'll ask you to step back. At this time, we'll open up testimony in support of a Senate Bill 312. If you are here in support of this measure, please come forward at this time. Again, 2 minutes, brief comments. State your name for the record. You may begin whenever you're ready.
Hello, Will Adler for the record. I'm here in support of Pyramid Lake Paiute Tribe and Duck Valley Shopai Reservation. I just briefly wanted to thank the Interim Committee of Health and Human Services for bringing forward this effort around tribal health authorities and having this greater engagement between state and tribal governments, and actually bringing in the federal government and kind of what happens when it comes to funding actual health and medical issues in the state. This bill is very complex in some ways, but very important in others. But I do believe it will create a new frictionless process that will help out all tribal nations in Nevada. So again, I want to log our support for SB 312. Thank you so much.
Thank you. Is there anyone else here who would like to offer comments in support of this measure? Seeing no one here in Carson City, no one in Las Vegas. ABH, is there anyone on the line who would like to offer support for Senate Bill 312?
Testify in support for Senate Bill 312. please press star 9 to take your place in the queue. Again, if you wish to testify in support, please press star 9.
Hello, this is Fabian Solis. I'm the Director of Health and Human Services here for the Las Vegas Paiute Tribe in support of SB 312 or 312. It's always critical to have a voice and to have collaboration for our population bases and the community as a whole, and reducing the barriers to have those voices heard, those concerns heard, is not only pivotal for addressing the issues of the people we serve, but also for just streamlining our capabilities and helping everybody understand each other. Communication is key, and the knowledge that we can share can create a far better future for Nevada, not only within our tribal community, but also within the state community as a whole.
Good afternoon, Chair Brown May and members of this committee. My name is Catherine Nielsen, and I'm the Executive Director of the Nevada Governor's Council on Developmental Disabilities. SB 312 provides an opportunity to strengthen outreach, trust, and coordination with Nevada's tribal nations, especially when it comes to supporting individuals with intellectual and developmental disabilities. And far too often, our council, along with many other programs, have struggled to meaningfully connect with tribal communities. There's historical and systemic barriers that have made outreach difficult, but the need is there and it is real. Tribal members with IDD deserve the same access to services, supports, and culturally competent care as every other Nevadan. And we believe that this is leaving behind the communities who are here first, and that tribal members with disabilities are welcome, included, and empowered through state programs and services. Thank you for your time and your commitment to inclusive policy.
Good afternoon. This is Anna Binder, Binder, for the record. So I was just calling in support of this. It is amazing. Brought to tears myself, and I just want to echo what Catherine Nielsen just provided in support testimony from our council. Thank you.
Chair, the public lines are open and working. We have no more callers choosing to testify in support at this time.
Thank you, AVH. At this time, we'll move into opposition testimony. If you would like to testify in opposition of this measure, please come forward here in Carson City or in Las Vegas. Seeing no movement here, AVH, is there anyone on the telephone line who would like to offer opposition for Senate Bill 312?
To testify in opposition to Senate Bill 312, please press star 9 to take your place in the queue. Chair, we have no callers choosing to testify in opposition.
Thank you, AVH. At this time, we'll move into neutral testimony. If you would like to offer testimony in neutral, please come forward at this time. Seeing no movement, AVH, is there anyone on the telephone line who would like to offer testimony in neutral on this measure?
To testify in neutral to Senate Bill 312, please press star 9 to take your place in the queue. Chair, we have no callers for neutral.
Thank you, AVH. We'll invite our bill sponsor up if you would like to make closing comments. No, we're getting a shaking our head no, so we'll officially close the bill hearing for Senate Bill 312. Thank you so much for being here today. That moves us to the next item on our agenda, which is the first item on our agenda. We will officially open the bill hearing for Senate Bill 257, and we will invite forward Senator Dondero Loop and her team to present.
Good
Afternoon, Madam Chair Brown May and committee members. My name is Marilyn Dondero Loop, and I represent Senate District 8 in Clark County, and I'm honored to be here to present Senate Bill 257, which revises provisions relating to autism. The National Autistic Society defines autism as a lifelong developmental disability which affects how people both communicate and interact with the world surrounding them. Signs of autism can be identified as early as 18 months old, and yet most people are not properly diagnosed until they are 5 years old. The Centers for Disease and Control and Prevention found that 85% of the children expected to have autism had developmental concerns noted in their records by 3 years old. 42% of them were diagnosed on the spot, 19% of them were diagnosed within the following 2 years, and roughly 39% went undiagnosed. Sometimes diagnoses were delayed because of difficulty in identifying the symptoms or escaping stigma and gathering the courage to take the first step to seek guidance. Other times diagnoses are delayed due to geographic location and the lack of access to specialty providers authorized to conduct autism assessments. This bill authorizes any healthcare provider to conduct the statewide standard for measuring outcomes and assess and evaluate people with autism spectrum disorders if it is within the scope of practice, and this expands the number of healthcare providers that can conduct these assessments, therefore expanding access. And with that, before we walk through the bill, with your permission, Madam Chair, I have at the table in Las Vegas, I have Dr. Gaspar de Alba, and I also have Mr. Brian Hager, and they are with the Grant-A-Gift Ackerman Autism Center. And if I could go to them and let them testify. Thank you.
Thank you. Go ahead.
Thank you, Senator Dondero Loop. Chair Brown, May, members of the committee. My name is Dr. Mario Gaspar de Alba, Gaspar, space DE, space ALBA. I'm an associate professor of developmental behavioral pediatrics at the Kirk-Kerkorian School of Medicine and the medical director at the Grant-A-Gift Ackerman Autism Center. Been practicing my specialty for about 15 years, and I've been here in Nevada since 2013. I had the opportunity to chair the state's Autism Commission, and I've served as a CDC Learn the Signs Act Early Ambassador to our state. I work with families affected by autism every day. Current legislation around the criteria for diagnosing autism spectrum disorders was established in 2009 in our state. At that time, the incidence was 1 in 110, less than 1%. The current rate, as of this year, is 1 in 31 children, or about 3.22%. Based on that number, we can estimate approximately 22,000 children in Nevada have an autism spectrum disorder. The National Autism Center at the A.J. Drexel Autism Institute reports the average age of diagnosis in autism in a child in Nevada is 5.5 years, compared to the national average of 5 years, and this is higher than any state that we border. This is a problem because studies have also shown that in some cases, autism can be diagnosed as early as 1 year of age, and we know that early intervention leads to better outcomes. Late diagnosis is associated with parental stress, and early intervention, which is critical to positive outcomes over time, if they are implemented before age 4, are associated with significant gains in cognition, language, and adaptive behavior. Researchers have linked implementation of early intervention in autism with improvements in daily living and social behavior. Collectively, the evidence suggests early diagnosis and intervention are imperative in the long-term trajectories and quality of life for children with autism. For that reason, the American Academy of Pediatrics has long recommended screening all children for symptoms of autism. They report, and I endorse completely, the following benefits of a primary care diagnosis of autism. First, it reduces wait times, or it provides earlier diagnosis. I believe in our state there are only 2 developmental behavioral pediatricians and a handful of neuropsychologists. Wait times for a comprehensive evaluation are long, and lost time is lost opportunity. Second, improving continuity of care. Patient and family can be seen much more often by their primary care provider than by a specialist. Third, reducing disparities in access to diagnostic services. Patients who are uninsured or less likely to be insured are less likely to be seen by a specialist. And lastly, assisting families in better understanding their child's strengths and needs for support. A primary care physician is more intimately familiar with not just the child's strengths, but the unique needs of each family. So by removing the prescriptive language surrounding the diagnosis of autism, We will reduce the administrative burdens on providers, especially primary care providers, and facilitate their effort to provide a more timely access to needed support services to children and families affected by autism. Primary care providers and other appropriate clinicians making autism diagnoses will continue to have access to specialists like me and neuropsychologists who can perform more comprehensive assessments if and when they are clinically indicated. This bill will allow for more children to receive critical therapy earlier and improve functional outcomes. Thank you.
Thank you, Dr. Gaspard. Thank you, Senator Don Loop. Good afternoon, Madam Chair Brown-May and committee members. For the record, my name is Brian Hager, H-A-G-E-R, President and CEO of Grant a Gift Autism Foundation Ackerman Center. As you heard Dr. Gaspar de Alba say, the incident rate continues to climb with 1 in 31 children diagnosed with autism spectrum disorder, and they face enough challenges. Accessing a timely diagnosis shouldn't be one of them. SB 257 helps to eliminate unnecessary barriers to a diagnosis and ensures more children receive the care they need when they need it. Back in 2009, Nevada was a national leader in passing NRS 427A.872, one of the first laws requiring insurance coverage for autism services. That milestone law laid the groundwork for progress in autism care, but over the past 16 years, demand has continued to outpace available resources. A prime example of the importance of this bill comes from Dr. Gaspar de Alba's practice as a developmental behavioral pediatrician. He will often diagnose ASD in a 4 or 5-year-old patient well within his scope of practice, yet insurance companies frequently reject these diagnoses, requiring an additional comprehensive neuropsychological evaluation, frequently either delaying therapy or stopping therapy at a pivotal time for the children. Families are then placed on a multi-year wait list at places like the Ackerman Center that accepts most insurances, including all Medicaid plans, where the wait for a neuropsychological evaluation can be 1 to 3 years. In the meantime, these children miss out on vital ABA therapy and early intervention services during their most formative years. SB 257 does not eliminate the need for psychometric, developmental, or neuropsychological evaluations. Those services remain essential and available when clinically indicated. SB 257 simply ensures that timely, qualified diagnoses can't be dismissed by insurers demanding unnecessary additional testing. SB 257 is about fairness and ensuring every Nevada child has access to timely, evidence-based autism care. It aligns state regulations with best practices in pediatric and neurodevelopmental care and eliminates arbitrary insurance barriers that delay critical treatment. Thank you.
Chair, Marilyn Dondero, for the record, I believe my experts are finished with testimony, but will be there for questions. And I'll quickly walk through the bill. And Section 1 defines the term a provider of health care. Section 2 prescribes the applicability, well, that was tough today, of that definition. Section 3 removes the requirements that the statewide standard includes a specific protocol, a standardized assessment instrument, and an evaluation. This section instead requires the statewide standard to align with best practice guidelines, in addition to direct observation and an assessment from a healthcare provider to measure behaviors consistent with autism spectrum disorder. Section 4 makes similar revisions relating to the early intervention services provided by the Aging and Disability Services Division of the Department of Health and Human Services. Sections 5 through 10 remove requirements that certain plans of health insurance coverage to be required specified health care providers make a diagnosis, develop a treatment plan, and provide care. Instead, Sections 5 through 10 require certain plans of health insurance to cover such diagnosis and treatment if the diagnosis, development of the treatment plan, and the treatment are performed by any provider of health care acting within his or her scope of practice. And Sections 5 through 10 also require an insurer to accept any diagnosis of autism spectrum disorder rendered in accordance with the statewide standard pursuant to Section 3. And with that, Madam Chair, I appreciate your time and your committee's time, and we stand for questions.
Thank you for the presentation. Thank you for being with us here today. We do have a couple of questions. We'll start with Assemblymember Goulding.
Thank you. wondering if you could clarify which of the healthcare providers' scope of practice includes the qualifications to diagnose?
Thank you very much for the question. And if you don't mind, Madam Chair, I will go down to Dr. Gaspar de Alba.
Thank you. Go ahead.
For the record, Mario Gaspar de Alba. So scope of practice would include developmental behavioral pediatricians, family practice physicians, neurologists, psychiatrists, as well as psychologists and neuropsychologists, as well as nurse practitioners with special training in the diagnosis of autism spectrum disorders.
Thank you. Next question from Assemblymember Nadeem.
Thank you so much, Madam Chair. Thank you for the presentation. My question with the doctor is that currently what is happening with regard to early autism diagnostics? Where we stand as of now?
Sure. So Dr. Gaspar Alba for the record. So right now, from the data that we have, early diagnosis is not early in our state. We're sitting at about 5.5 years on average for diagnosis, and that's not early. Early would be 3 or younger. And so what we're trying to do is trying to get the other practitioners practicing in their scope of practice to be able to diagnose autism and refer for therapy earlier without having to wait for the currently mandated comprehensive evaluations. Does that answer the question?
Thank you. Assemblymember Hibbets.
Thank you, Chair. My question actually goes back to the Section 1 list provider of healthcare. And in Section 1, it says provider of healthcare is defined by NRS 629.031. And in Section 3, Sub 2, it goes back to the language of within scope of practice. Don't you think it would be easier to actually list those professions that Dr. Gaspar listed as opposed to I lost count, but it goes through A through GG, and then trying to figure out which one of these actually fit, like V, an athletic trainer, probably doesn't fit in scope of practice. So I just think it might be easier to list those occupations that Dr. Gaspar had listed himself.
Marilyn Dondero Loop for the record. Dr. Gaspar de Alba, did you want to answer that, or I can?
I think that sounds more like a political question than a medical question.
So this was a discussion when we actually did this particular bill. And one of the things we wanted to do was to put enough description in there so that we had, in other words, you're probably not going to go to a geriatric doctor to get an autism, although you could be an older person seeking that information. But what we wanted to do is to allow these families to be able to get, if I go to my pediatrician, they may suggest to me that my child has maybe some autism specifications that they're seeing, and they may refer me to someone. And so that's how that usually works. And when we have the Ackerman Center, the families that show up there most likely, and Mr. Hager, you can correct me if I'm wrong, but the families that show up there most likely have already been to a doctor of some sort, and they have been referred there or sent there for further evaluation. Mr. Hager?
Thank you, Senator. Brian Hager for the record. That is correct. They will get a referral from their general pediatrician or family practitioner to see Dr. Gaspar de Alba or one of our other providers at the Ackerman Center for the diagnosis.
Dr. Gaspar de Alba for the record. So just to add, I think one of the reasons for being less specific and including healthcare providers within their scope of practice is to try to eliminate as much as possible loopholes on insurance reimbursement for services and who is accepted. But your point is taken, Council Member. Thank you.
Thank you. Okay. Next question from Assemblymember Gray.
Thank you, Madam Chair. I really appreciate what you're trying to do here, ma'am, but one question I have that's nagging at my mind, do we risk overburdening a system and resources that are already being stretched thin with, potentially people receiving a diagnosis that they may not actually meet? I'm concerned that, we see parents all the time. Well, my kid has ADHD. The parents, they push for a diagnosis. Sometimes they get it. Parents take their kids to the doctor and they don't feel good. They don't feel anything's been done unless they leave without an injection of antibiotics or something. It's just, I find, having been in healthcare for so long, I find it really easy for the doctors sometimes to cave to the parents' will. And I'm just really concerned about the resources available to treat, especially the severely autistic.
Marilyn Dondero, for the record, thank you very much for the question. In my mind, as a parent and a grandparent, I would think I would be thrilled to death if I found out that my children were not diagnosed with some type of a disability. I don't think anybody goes to any doctor or any nurse looking for an autism diagnosis. And we have a waiting list for these children. And if somebody goes to, like the Ackerman Center or some other facility to get a diagnosis, I think that's not something you do just randomly, like going to your doctor and saying, my kid has an ear infection. An ear infection is a way different thing than an autistic diagnosis. So in my opinion, I would think that we are on the right track to have these children diagnosed, and it's an unfortunate situation that we have children waiting. And Mr. Hager or Dr. Gaspar de Alba, if you have anything to weigh in on, please go ahead.
Absolutely. Dr. Gaspar de Alba for the record. Assemblymember Gray, that's a good question and a legitimate concern for sure. There's always the risk of misdiagnosis. I think one thing that needs to be considered is while we are talking about children receiving a diagnosis so they can start therapy, and that system in our state is already overburdened. That is true. There are benefits to a family knowing what's happening with their child, even if they are waiting to get the services. If they know what the diagnosis is and they know what's happening, there are resources beyond waiting to start ABA therapy that they can access, information, things that they can learn about, even services through school. There are opportunities for them to understand better what's happening with their child beyond just waiting for ABA services. And I think that's beneficial to families.
And Marilyn Dondero Loop for the record, and I can tell you as a longtime 30-year educator and an early childhood person, the earlier we can do things with children, anything we do with children, the earlier we do it, the better off we are.
Nope, I agree with you, Senator, and I appreciate the answer, Doctor and Senator. Kids are the way to my heart. If anybody doesn't know anything about me, that's one thing they should know about me. One final question on this, though, is being diagnosed with ASD, is that how can I say this? Is that a qualifier for Social Security disability?
That might be above my pay grade. So I'll go to Las Vegas and see if either one of my experts know that answer.
Okay, that's a little bit above my pay grade as well. I know that of so many patients of mine that have tried to qualify for that, some have qualified and some have not. So I don't know for sure, but in my experience, it hasn't been an automatic qualifier.
Thank you, members. Any other questions? No, seeing none, thank you so much, Senator, for the presentation. We will go ahead and open up testimony in support of this measure. If you'd like to offer testimony in support of Senate Bill 257, please come forward here in Carson City, as well as in Las Vegas. Go ahead and fill the chairs in. You have 2 minutes. State and spell your name for the record. You may begin when you're ready.
Hello, Chair Brown May and members of the committee. My name is Carissa Pierce, CARISSA-PEARCE, and I am representing Children's Advocacy Alliance. We are in strong support of SB 257. This bill uplifts Nevada's healthcare workforce and ensures that children with autism spectrum disorders can receive timely diagnosis. Best practices indicate the necessity of early diagnosis, and diagnosis is essential for receiving or to be eligible for treatment services. Early diagnosis means access to therapy, resources, and support that can positively shift the projection of a child's development. Long wait lists mean children miss critical windows for early intervention from birth to 3 years old, and this is especially critical for kids in underserved communities who are often diagnosed later than their peers, delaying life-changing interventions. We want all of Nevada to be a place where every child has the opportunity to succeed, and SB 257 is a step toward making that happen. Thank you for the opportunity to provide testimony and for your commitment to Nevada's children.
Good afternoon, Madam Chair, members of the committee. For the record, Andrew McKay, I'm the Executive Director of the Nevada Franchised Auto Dealers Association. You guys are probably wondering, what's the car dude doing up at the rostrum? Simply put, this is an issue that is near and dear to my board and our members' hearts. Mr. Ackerman is on our board. His company's been in business for, I think, now 104 years. And he and his wife are the namesakes of the Ackerman Center, and hence why I'm here. Simply put, SB 257 will provide significantly more options and access to care for evaluation, diagnosis, and treatment of ASD. By busting down the time barriers, our children and families will be able to have a better chance at seeking treatment and being treated for autism and the spectrum disorders, and potentially living normal lives. And for that, Madam Chair, members of the committee, we enthusiastically support this bill, encourage your support of it, and prompt passage. So thank you for your time.
Good afternoon, Madam Chair and members of the committee. For the record, my name is Mary Przenski, here representing Nevada Association of School Superintendents, and we're in support of the bill because of the earlier diagnoses of some of our students. You know, you have some kids who are in school and are really struggling, and you don't really know why they're struggling, and they may have an autistic they're autistic. So, any rate, we think that the earlier diagnosis will help us in the schools. Thank you.
Thank you. We'll go ahead and take comments in support in Las Vegas. Go ahead when you're ready.
Good afternoon, Madam Chair and members of the committee, and thank you so much, Senator Darrell Loop. I'm Michelle Scott Lewing, MICHELLE SCOTT-LEWING. I'm president for the Autism Coalition of Nevada, representing our statewide population. Also, I am an executive vice president in medical devices, and particularly in pediatric neurosurgery for 33 years. So I have extensive experience in early childhood development, and I also have 2 adult children on the autism spectrum. And I want to say that the very first person that identified autism in my son Chase was our pediatrician. It's a funny story. It's short, but basically at 18 months, he told me that he felt that my son had autism, and I 100% disagreed with him and denied that. But that's the funny but not funny part. But I think it's important to point out that pediatricians and primary care physicians are the front line. They are typically with our children from infancy going forward. And I also want to point out that the whole plan here is for early intervention. We have NEIS. We have Know the Signs, Act Early, which is a motto that we've been touting for 20 years. So that is the mission, right? Early diagnosis. So we want to make sure that's as early as possible. 5.5 years old is way too late. A child who has developmental delays and is delayed in talking, like my children were until they were 5 years old, they need that intervention early as possible, so they have a running chance at the ability to be able to talk, the ability to be able to move into their hallmarks as, milestones as they should. So I'm respectfully asking for your support in this bill, and I want to thank you so much. And I'd like to say that, for the record, the Autism Coalition of Nevada is strongly in support of this bill. Thank you so much.
Good afternoon, Madam Chair, members of the committee. Yesenia Gonzalez for the record, Vice President of Azul Blue United by Autism. As we all know, early intervention is key for our special needs children, and the sooner a diagnosis of services, the better for the individual. I come not only as a representative to Azul Blue, but also as a mother who has autism. I'm 40 years old, who had to fight tooth and nail for my son Matthew and have an IEE, as many of our families have or try to, just to receive a diagnosis and fight for dire services. We support Senate Bill 257 as we firmly believe that this bill will stop the disparities in our community when it comes to finally getting a diagnosis, God willing, in a timely manner versus years. Many of us were and have been on waiting lists to see providers for medically deemed necessary services, and many times we have to fight to get network gap exceptions just so our children could get the vital services they desperately need. My son was nonverbal. He is now quite the chatterbox and never ceases to amaze everyone with how smart he is and the music he makes. Early intervention services were his saving grace at the age of 3, and finally having a diagnosis, Asperger's, when he was 6 years old. He's now going to be 16 years old, and his doctor at the Ackerman Autism Center back then, Dr. Gaspar, a huge supporter in our autism community, as we all immensely love him for his advocacy, diagnosed my son with global level 1 of autism. So please hear our pleas and support this bill to break the barriers and assist providers and help our many families in Nevada. Also, many may not know that autism is not just autism. Many times it comes with other things like ADHD, like my son, like myself. It doesn't define us. It doesn't change who we are. Thank you.
Thank you. Seeing no one else here in Carson City or in Las Vegas, AVH, is there anyone on the telephone line who would like to offer support for Senate Bill 257?
Testify in support for Senate Bill 257. Please press star 9 to take your place in the queue. Again, if you wish to testify in support, please press star 9.
Good afternoon, Madam Chair, members of the committee. This is Anna Marie Binder, ANNAMARIEBINDER, and calling in support of this. I want to point out I initially individually wrote in an opposition back in March, and that letter highlighted a lot of the concerns that other assembly members have expressed here today. And but after meeting with Brian and Dr. Beasley and kind of walking all of this through, I am rescinding not all of that opposition with some reservations, but stand in support for the passage of this bill. Additionally, through months of meetings with the Commission on Autism Spectrum Disorder, I am also happy to report that the Commission has voted unanimously to also support this bill. And I will be submitting their letter after this meeting probably. And then as well, I believe our Council on Developmental Disabilities has also chimed in historically in support of this. And I did want to make just one technical little correction. We refer to severe autism professionally as profound. And I just wanted to let the speaker of that know that that is our appropriate way of addressing that now. And so anyways, and I do just want to say thank you for early intervention services. My youngest son was diagnosed under 1 year old, went right into early intervention, went into the school district at 3. He is now entering the 4th grade, and for the first time in the 25 school year, was the highest achiever in his growth testing in his class. So early intervention is key, and it leads our children somewhere, which is better than nowhere. Thank you.
Hello, my name is Rebecca Raynoa. That's Raynoha. I'm in full support of SB 257. I am both a mother of a special needs child that has received 3 different diagnoses from state licensed psychologists as well as a practitioner. On a weekly basis, we get so many referrals from pediatricians' offices to evaluate and treat autism that they're not willing to actually put the diagnosis on file. Some of my most recent cases, I had 2 children, ages 4 and 6, that came in with aggression, head banging, toe walking, self-injury, nonverbal by the ages of 4 and 6, lining up objects, pica, like all of the classic signs and symptoms. When the doctor had sent the referral in, they said, we don't diagnose here. And they had been already on the waiting list for Dr. Gaspar for over a year. Nevadans are begging you to pass this bill. The doctors that are leading in the diagnosis are begging you to do this bill, please. And thank you.
Good afternoon, Chair. My name is Eve Erickson Woodruff. That's ERIKSSONWOODRUFF. As a mother of a child with level 3 autism and an advocate for autism families, I strongly support SB 257. I know firsthand what it's like to search for support and answers while navigating these challenges, these overwhelming challenges sometimes with our children. And Nevada's families are suffering. They're confused and they're locked on how to access treatment for children, often stuck on wait lists. Some families I've talked to have been on wait lists for over 2 years. This vital legislation addresses these challenges, ensuring better support and clearer pathways for individuals with autism. I urge its swift passage to make a meaningful difference for our families and our community. Thank you.
Caller with the last 3 digits, 744, please press *6 to unmute yourself. Caller with the last 3 digits, 744, please press *6 to unmute. Chair, there appears to be a problem with this caller. Would you like to move on to the next one?
Thank you, AVH. Yes, please.
Chair, members of the committee, Stephen Cohen for the record, did authenticate you.
Good afternoon, Chair Brown-May and members of the committee. This is Catherine Nielsen again from the Nevada Governor's Council on Developmental Disabilities. I will make mine very brief. We receive calls from parents on a regular basis about getting autism diagnosis and treatment services, and SB 257 we feel will enhance access to autism diagnosis and treatment services, and thank you for hearing this bill.
Caller with the last 3 digits, 678, you are unmuted and you may begin.
Thank you. Enough doctors who can diagnose. Early diagnosis will allow early treatment, early intervention, and the best chance of success
for people with autism and their families. Thank you for hearing this bill.
Chair, the public lines are open and working. We have no more callers choosing to testify in support at this time.
Thank you, AVH. At this time, we'll move into opposition testimony. If you would like to testify in opposition on Senate Bill 257, please come forward here in Carson City or in Las Vegas. Seeing no movement, AVH, we'll go to the telephone line. Is there anyone here who would like to offer testimony in opposition on this measure?
Testify in opposition to Senate Bill 257, please press star 9 to take your place in the queue.
Good afternoon, members of the committee. My name is Deanna Yates. I would like to take a moment to explain why I am in severe opposition of SB 257 as written, because the providers that can diagnose is too vague. It is a very well-intended bill, and I understand all of it. However, the concern still stands that if a provider possibly attends a short educational course in autism, then they'll feel that now it's within their scope of practice. If the providers that were listed, like Dr. Gaspar has said, that would be completely different. I would be in 100% support of this bill. But because it includes dental hygienists. It's ridiculous the way that it's worded. I would like to give an example, a personal example. My son, when he was 3 years old, his pediatrician diagnosed him with autism. He wanted him to go to ABA, wanted him to have all kinds of different things. Instead, we went through speech and OT. They correctly diagnosed him with, instead of having autism, he actually had sensory processing disorder and developmental delays. He was treated properly with the necessary therapy that he needed, and he is now a happy and healthy 10-year-old with the correct diagnosis and getting the correct stuff that he needs. If the bill says who is actually trained and it's within their scope of practice, that will be much better. Thank you for your time.
Good afternoon. My name is Jessica Garrett. I'm a speech language pathologist and private practice owner. I'm here to voice strong opposition to SB 257 in its current form. I absolutely support diagnoses being more accessible and support more medical providers being able to provide this diagnosis. However, SB 257 proposes allowing any healthcare provider to diagnose autism without clearly defining who qualifies or what training is required. Autism is a complex neurodevelopmental condition, and accurate diagnosis requires expertise in early development, differential diagnosis, and co-occurring conditions. Even more concerning, the bill removes the requirement for standardized assessment tools, allowing diagnoses to be made through observation alone. This contradicts best practices and risks misdiagnosis. Let's be clear here. An autism diagnosis is not required to access early intervention, speech, occupational, or physical therapy. The true intent of this bill seems to be expanding access to applied behavioral analysis, or ABA services. But ABA is not a therapeutic intervention. It is a behavior management system. Lowering diagnostic standards to meet insurance criteria and to decrease wait lists is deeply problematic. This could lead to overdiagnosis, misidentification, and inappropriate services for children with other support needs like ADHD, trauma, language delays, etc. These errors can follow a child for life, impacting education, services, and social-emotional well-being. Lowering the standards to address waitlist concerns is not a solution. It is a short-term fix that creates long-term harm. If Nevada wants to improve access, the answer is not to lower the bar. It's to invest in qualified interdisciplinary teams and expand responsible evidence-based diagnostic capacity. I urge you to oppose SB 257 unless it is significantly revised to clearly define who can diagnose autism and require the use of standardized tools and autism-specific training. Thank you for your time and for protecting the integrity of care for Nevada's children.
If you have recently joined and would like to testify in opposition to Senate Bill 257, please press star 9 to take your place in the queue.
Good afternoon. For the record, my name is Dr. Lori Drucker, Lauriedrucker. I'm here on behalf of the Nevada Psychological Association. We as an organization support the intention of this bill to reduce the backlog of autism assessments in Nevada, and we agree that early diagnosis and intervention for autism services benefits children and families. We support changes to the statewide standards of assessment so that there will be fewer delays in authorizing insurance authorization for needed services. Most children who will qualify for an early autism diagnosis will be evaluated by their pediatricians and referred to treatment services, which should be covered by insurance companies according to generally accepted standards of care. Our concern is that expanding the range of any provider under NRS 629.031 will lead to insufficiently trained professionals assessing and misdiagnosing autism. We are concerned that inaccurate diagnoses contribute to increased costs for reassessing autism diagnoses and for increased referrals to ABA services that may not be warranted. NPA urges the committee to consider amending the language to clarify which providers may diagnose ASD and that they do so within their scope of practice and competency. We suggest provider groups under NRS 629.031 be limited to those providers acting within his or her scope of practice and competency to provide autism assessment, diagnosis, and treatment services. Thank you for your attention to this important bill.
Caller with the last three digits 744, please press star 6 to unmute yourself. Caller with the last three digits 744, please press star 6 to unmute.
Chairman Brown, May, and committee members, I was on the phone for support, and I understand that for some reason there was difficulty and you could not hear me. Can I still testify in support?
Thank you. Go ahead. We'll take your testimony in support. Go ahead.
Thank you. I'm grateful for your time today. For the record, my name is Jan Crandy, Crandy. I served on the Nevada Commission on Autism as the chair for many years. I was an advocate and was part of the team who helped with the drafting of the original bill language for diagnosis standards in Nevada in 2009. At the time in Nevada, there was very little to ensure proper evaluations and assessments were given or the collection of entrance and outcome data. We wanted to make early diagnosis the norm in Nevada. Currently, this statute now only allows a handful of providers to diagnose. The current language in statute is now creating barriers to diagnosis. Without a diagnosis, our children cannot access treatment. I am sad to see after all these years, we still have a wait list for children to get a diagnosis so they can start treatment. I know personally what a difference an early diagnosis and receiving early intensive ABA treatment can make. My daughter Megan was diagnosed at 24 months. She's 30 years old now. We should not be having kids wait till they're 5 years old or 6 years old. Received intensive ABA treatment. She testified here for the bill that required insurance coverage for autism treatment. She lives totally independent, works full-time as a cashier, and even lives in another city without our oversight. She continues to be involved with community. She's in love and in a healthy relationship, maintains her apartment, never calls in sick. Her job is important to her. She pays taxes and has benefits through her job, health insurance. So when I say I know, I really do. When children start treatment late, after the age of 6, this outcome is not possible. An early diagnosis and treatment can be the difference between leading an independent life or a life dependent on some level of support. Everyone deserves to reach their full potential. Thank you to all of our sponsors. I'm so grateful that you brought this bill forward. It's an important piece of legislation. With hope, please pass this bill. Thank you very much.
Thank you, Ms.
Chair,
Crandy.
we have no more callers.
Thank you. Go ahead, ABH.
Chair, I do apologize. We have no more callers for opposition at this time.
Thank you, AVH. Ms. Crandy, I just want to say, if you're still listening, thank you for sharing the success story of your daughter. It's great to know that she has progressed so wonderfully through the services that she received. At this time, we'll move into neutral testimony. If anyone is here who would like to offer testimony in neutral, please come forward at this time. Here in Carson City, I'm not in Las Vegas yet. That's next week. Here in Carson City, go ahead. You may begin when you're ready.
Thank you, Madam Chair, members of the committee. Adam Plain, Plain, with the Nevada Division of Insurance. I did submit written testimony, should be up in Nellis. I wanted to say that because Senate Bill 257, while it deals with insurance issues, primarily focuses on the diagnosis and the insurer's requirement to accept a dispositive diagnosis. The division has reviewed Senate Bill 257 and determined that it does not trigger federal defrayal provisions. Thank you.
Thank you for your comments. It's nice to see you here in the policy committee. Thank you. Okay, seeing no one else here offering comments in neutral and no one in Las Vegas. AVH, is there anyone on the telephone line who would like to offer comments in neutral?
To testify in neutral to Senate Bill 257, please press star 9 to take your place in the queue. Chair, we have no callers for neutral.
Thank you, AVH. At this time, we'll call the bill sponsor back up. Senator, if you don't mind, I have just a clarifying question. I have Section 1 of the bill in front of me, and it seems like the questions that we're getting are really about scope of practice. The language that I'm looking at, though, says on page 3, Section 1, Section 3, sub 2, the statewide standard prescribed pursuant to Section 1 must authorize a provider of health care to directly observe a person and complete an assessment. And if I go on, it's such opposite completing an assessment are within the scope of practice of the provider of health care. So it seems as though scope of practice has been amended into this bill in several sections. Was that a conversation? Is this the original form? Are you aware of, or is it? It just seems like we have added scope of provider of health care acting within his or her scope of practice after they have assessed a person for whom the treatment plan has been developed. It seems like scope of practice has been added in throughout the bill. Was that a conversation that you had as a way to make this better?
Marilyn Dondero Loop, for the record. Yes, it is a conversation that we had on the other side, and we did make it clear scope of practice, meaning your orthodontist, your whatever, may not, give you, and I don't say may not, probably won't give you that diagnosis. It will be a pediatrician, a general practitioner. That would be within their scope of practice. Is that what you're asking?
Thank you, Senator. That is what I'm asking, right? I wanted to be able to clarify that we're not just allowing anyone to offer autism diagnosis, but that it is intended for this measure for it to be within their scope of practice, that they could do that initial diagnosis and referral for questions. I know that Dr. Assemblymember Edgeworth has a question, if you'll allow it.
Yes.
Thank you. I really appreciate you bringing this, and I appreciate that we want to get early diagnosis and widen the scope. But specifically in section, this is close to the section she was talking about, section 5B, where it's talking about person diagnosed. There was a list of people which similarly reflected the list that the doctor suggested. It was not including APNs or nurse practitioners. It doesn't include PAs, and physicians certainly have that. But it is a little concerning that is there a legal definition of within this scope? Because technically there's a lot of things within my scope as a physician.
Correct. And I think that when we first started, you can see in 5A, for example, Section 5A, where it says a licensed physician or licensed psychologist. We were trying to broaden that a little bit so that if a person went to someone and they said, your child may have autism, you may want to seek further information or diagnosis, that they could use that, because what's happening is if these children with parents that don't know the medical system, don't even know what autism is, and they go to someone and they give them that suggestion of diagnosis. We wanted them to be able, they may then go to you as a doctor, or they may go to a pediatrician who says, yes, I think you probably need further evaluation, or they may go straight to the autism center where they might get that diagnosis. I don't know if that exactly answers your question, but we've had both sides of that coin, discussed. Some were, we needed to be just a provider of health care, and we had other people who said only a licensed physician or licensed psychologist, and that was much narrower. So I don't know if that helps, but, and I don't know that Dr. Gaspar de Alba was still in Las Vegas. He had another appointment that he had to go to. I'm happy to get you some more information, but we did have it one way and we went the other way. And sometimes with our bills, as you well know now, there are opinions or people weighing in and on both sides.
Thank you for the answer. I guess what my question should have been is, would you be willing to be a little bit more specific about which providers are able to diagnose? You said earlier that primary care is the front line and that those are the ones that should be diagnosing. Totally agree with that. Physicians are trained to do this. My concern is that there are people that literally aren't doctors that have been giving me medical advice, and they consider scope of practice is a little bit vague in nature. And I just wonder if more specific would be better.
I feel, Marilyn Dondero Loop, for the record, I feel your pain because everybody thinks they're a teacher. I don't know what to say. We're experts in all fields.
Thank you, Senator. That's very well said, and I sincerely appreciate that. Thank you. If we're good at this point, I'm going to go ahead and close the hearing. I'm going to say thank you so much for what you've done. We've heard in support and opposition and neutral, and so we'll go ahead and follow up on this measure offline. We look forward to having a further conversation to getting the bill where we can potentially move it forward today. So that's where we are. I appreciate you. Thank you so much. With that, we have officially closed that bill hearing now twice on Senate Bill 257, so we're definitely not going to hear that one again. Let's move on and welcome our distinguished senator back and open up the bill hearing for Senate Bill 353.
Thank you very much, Madam Chair. For the second time, I'm still Marilyn Dondero Loop, representing Senate District 8 in Clark County, and I'm here today to present Senate Bill 353 in its first reprint, which creates a billing category and a reimbursement rate for mental and behavioral health services provided to Medicaid enrollees at certain clinics. Medicaid is the single largest payer for mental health services in the United States and remains a critical pathway to accessing health care. Ensuring access to mental and behavioral health services for Medicaid enrollees is a fundamental aspect of the Centers for Medicare and Medicaid Services mission of supporting the overall well-being of individuals through essential care. Chair, I'll summarize the first reprint of this bill. This bill requires the Division of Healthcare Financing and Policy of the Department of Health and Human Services, also referred to as Nevada Medicaid, to create a specific billing category within the Medicaid Service Manual to the extent of available federal participation. This category is intended for clinics operated by an accredited university within Nevada or pursuant to a faculty practice plan to which a university is a party that provide under the direction of a physician, mental or behavioral health care to Medicaid enrollees, education and training to trainees, completing a degree, supervised clinical hours, or other requirements for registration, certificate, or license as a mental or behavioral health professional. In addition, this bill establishes two separate all-inclusive per diem Medicaid reimbursement rates for services provided by certain trainees during a visit to a clinic or describes where the services must be provided by the clinic. This bill also requires DHHS to apply for any waiver or Medicaid state plan amendment or other federal authorities to carry out the bill's provisions. Lastly, the bill defines terms used throughout the bill. And with that, I have Dr. Zimring and Ms. Moore down in Las Vegas, I believe, from UNLV to answer any questions. And I believe I may also have a couple others in the audience. So with that, I will stop and pause for questions.
Thank you, Senator, for the presentation. We appreciate you. Members, are there any questions? Assemblymember Hibbets.
Thank you. Senator, just a quick clarifying question. You said in your testimony you kept referring to the first reprint, but we have the second reprint. I just want to make sure we're both working off the same copy.
Apologies, it's just within my remarks. I said first reprint.
No problem. I'm extremely tired, so I thought I might have missed something.
You know, 11:30 comes quickly in this building.
Any other questions, members? Well, this is a stark contrast. Thank you so much. Senator, thank you so much for the presentation. We'll go ahead and ask you to step back. We'll open up testimony in support of Senate Bill 353. If you'd like to offer support of this measure, please come forward at this time. Again, in support, ditto, all of the above, and 2 minutes. Feel free to state and spell your name for the record. You may begin when you're ready.
Good afternoon, Chair Brown May, members of the committee. For the record, Patricia Charlton, Chancellor, Nevada System of Higher Education, and just wanted to thank the bill sponsor for putting forward SB 353. And on behalf of the Nevada System of Higher Education, we strongly urge you to pass this bill. Thank you.
Hello, Chair Brown May and members of the committee. My name is Carissa Pierce. CARISSAPEARCE, and I'm here with Children's Advocacy Alliance, and we are in strong support of SB 353. This is an important initiative for improving access to mental and behavioral health services for children and families and appropriately reimbursing folks for doing mental health work in Nevada. Thank you for the opportunity to testify, and please support this bill.
Hello, Chair and members of the committee. Sheila Bray with the University of Nevada, Reno. We too are in full support and just thank the Senator for bringing this forward. We think it's just an innovative idea to allow us to expand into another scope of practice. Thank you.
Good afternoon, Chair Brown May and members of the committee. For the record, Bernard Benavides with UNLV. Here strongly in support of SB 353 and the work of Dr. Michelle Paul and the practice for this important work in behavioral health in the state. Thank you.
Thank you. Is there anyone else here who would like to offer testimony in support of Senate Bill 353? Seeing no one else moving here in Carson City, no one in Las Vegas. AVH, is there anyone on the telephone line who would like to offer support for Senate Bill 353?
Testify in support for Senate Bill 353. Please press star 9 to take your place in the queue. Again, if you wish to testify in support, please press star 9.
Good afternoon, Madam Chair, members of the committee, Anna Marie Binder. Again, for the record, I'm just going as a parental ambassador for the Children's Advocacy Alliance. I will echo and ditto their support testimony for this. Thank you.
Chair, the public lines are open and working. We have no more callers choosing to testify in support at this time.
Thank you, AVH. At this time, we'll move into opposition. If you would like to offer testimony in opposition of this measure, please come forward here in Carson City or in Las Vegas. I see walking, but not toward the table. Thank you. So no opposition here at this time. AVH, is there anyone on the telephone line who would like to offer testimony in opposition on this measure?
To testify in opposition to Senate Bill 353, please press star 9 to take your place in the queue. Chair, we have no callers for opposition at this time.
Thank you, AVH. At this time, we'll move into neutral testimony. If you would like to offer testimony in neutral on this measure, please come forward here in Carson City or in Las Vegas. Seeing no one coming forward to offer neutral testimony, AVH, is there anyone on the telephone line who would like to offer testimony in neutral?
To testify in neutral to Senate Bill 353, please press star 9 to take your place in the queue. Chair, we have no callers for neutral.
Thank you, AVH. Would you like to make closing comments? Thank you. Our sponsor is saying no closing comments. We appreciate your time today. We will officially close the bill hearing for Senate Bill 353. Thank you so much for being here. Next up, I would like to welcome our bill sponsor for Senate Bill 192. Senator Neal has been sitting with us for quite a while this morning or this afternoon. Or is it this evening? I don't really know. Senator Neal, thank you so much for being here with us today. Take your time. You may begin whenever you're ready.
Senator Neal, for the record, here to present SB 192. I do have, I believe, either Mr. Roque online or Dr. Bayo. So Dr. Bayo is an expert to discuss Section 29, and then Mr. Roque for Section 19. I don't know if they're on the line, but they would be treated as co-presenters, not support.
Thank you. I see someone on Zoom, Senator.
That's Mr. Roque.
Great.
And then Bayo would be calling in, Dr. Bayo. So we're working from the second reprint of SB 192. I'm just going to quickly kind of break down these sections. So this is what I consider to be my omnibus version of a healthcare policy. So I'm just going to get right into it. So in Section 1, Office of Minority Health came and discussed with me about an inequity that was happening related to deaf or hard of hearing persons who were giving birth, and how there were no sign language interpreters that were actually in the hospital, and they were still doing it by telehealth, and that it was a concern around equity, equity and direct care of persons who may not be able to hear, and how their birth experience actually happens within the hospital. And if anyone, few members have given birth, the idea that you have to look at the screen in order to see a interpreter try to tell you what's going on and then sign back to the physician creates multiple complications if you do have a complicated pregnancy. But even if it's just a regular pregnancy, I think it creates problems and inconsistencies related to the care in that process. So that is what Section 1 is trying to get at. There were some amendments accepted, so it's like if a sign language interpreter is not available, you're not sitting, waiting around, trying to determine whether or not you're going to proceed with the birth process because the interpreter is not available. Section 19 relates to the EKG, because there were a lot of sections that were deleted, but the major sections, Section 19 relates to the EKG or ECG, which is associated with large school districts. So there's been an ongoing issue around pre-sport heart screenings and whether or not we can identify whether or not a student may be at risk before they go out and play sports. So currently the data says it's not 90%, but there was a Florida study from their Office of Programs and Accountability, December 1st of 2021, where EKG may help identify 60% of the diagnoses related to cardiac death. So the way that the Florida Office of Programs and Accountability listed the guidance and criteria was that, number one, you need to have law or policy, but you also need to make sure that a student is evaluated by a physician. So the way the language, and we talked to the sports, I don't know what they're called, NCIAA. They spoke with me and Mr. Roque, and if you guys have different additional questions, you can field them to him. That basically the school would adopt a policy, and then if practicable, then they would receive an EKG or ECG. And so I know that you guys have heard some opposition on Section 19, but we put in the if practicable, which was our amendment on the other side, because maybe there are insurance issues, maybe this is something they cannot do, trying to just give that wiggle room within that particular section. So if you've looked at the fiscal note, also for local governments, CCSD has already entered into an MOU in order to start the process related to an ECG or an EKG. And so it's already happening, right? And we don't have necessarily any kind of guidance or policy in place, but the school district would then further elaborate on deeper details of the policy outside of what the statute says. So in section 22, this was a provision that popped up, and it's also working with certain stakeholders around what I really wanted to do. But I was getting into the issue around foster youth and how they are being diagnosed when they're being aged out. So I had started asking questions, 23, 24, around to the biostatistician, trying to figure out how are we diagnosing foster youth and whether or not we have a secondary assessment before they get released. And so when I got the data, it seemed that youth were keeping the same diagnoses that they may have had at 6 and still have the same diagnoses at 15. So it made me want to ask the question of, is there a reassessment? Does the child, if they had multiple diagnoses, complex diagnoses, why are not some of these coming off if we're doing some level of mental health treatment, behavioral treatment? And so when I talked to, it was an FQHC and a psychiatrist that works in this space, we found out a couple things, right? That there were 2 kinds of behaviors that were happening. One, that learning that the more complex the diagnoses, the more interest there is in maintaining that particular youth, because they're actually they're worth more in regards to the care and what is charged because of the multiple complex diagnoses. The second thing that we learned was that because they're foster youth and more vulnerable population, that they were keeping the diagnosis so they could keep the insurance on them after they aged out, because they were more worried about the lack of insurance that they would encounter or the reduction in services that they would encounter if they were no longer on their insurance. And so the question for me and for Section 22 was, what if the diagnosis is actually changed and the student or the child does not know that diagnosis is different? It changes, number one, your life outcome, your life viewpoint, how you interact, because you're still believing that a certain mental health diagnosis is still on you. And so it also brought up a larger question on the functionality of foster youth in the space, because they have been a consistent group within our workforce plan in the state for over 12 years as a target group in order to assist into work. And so I just started to think about, when we talk about whole child in education, whole child in foster youth, and whether or not this particular student has the proper diagnoses upon exit, and trying to make sure that there was some kind of assessment that was diagnosed from a range of folks. Could be a psychiatrist, psychologist, or advanced nurse practitioner, because we know that in the settings, sometimes it is the nurse practitioner, not necessarily the psychiatrist, who may be engaging in the diagnosis. So the next portion of the bill, which is, it's Section 26, but I know I submitted an amendment to you guys because I feel like the amendment has not caught up that happened in finance, which was there was supposed to be a total deletion of Section 26. And so I don't want to discuss that portion because I was initially in the bill, I was trying to go after monopolies, but I made an agreement to delete that out in entirety. And so that should not be a provision that we discuss. And so I've been going back and forth with legal while I've been sitting in here on whether or not just trying to make the amendment catch up with the current version of the bill. So the next portion of the bill that I wanted Dr. Bayo to speak to was Section 29, which it relates to race-neutral formulas associated with healthcare. And so why this was coming up is because we've heard several things around lung tests, the performance of the pulmonary function tests that might have some level of race bias. also kidney test, cesarean. And so the idea here was in a race-neutral formula was to get away from, or at least not have in totality, the use of race, but also other factors, right? So there are genetics that might also play into why a person may be predisposed, or other social determinants of health. But because medical science, some portions of medical science were built on the fact that there might be a racial component associated with why a person is more susceptible to a disease, may not also always be accurate in determining whether or not someone actually is affected by a particular disease. So one thing that was found out in the study from National Institutes of Health was that there was a certain level of bias when it came to lung tests, where that the bias contributed to race being used in the pulmonary function test rather than other factors known to be associated with pulmonary function, such as smoking, body mass index, and early life events. And so that particular portion, I really wanted Dr. Bayo to get into. She's a physician in Reno, and this is her expertise. She's gone national on these topics. And so I wanted, if you guys have questions for her, I think she's the better person to discuss that. The next portion of the bill, I believe, is, well, Section 35 also has the race-based information, but I want to skip to Section 43, which I was asked to include a provision in here related to insurance coverage related to doulas. Why it came up to me, because they were saying that doulas were not being treated as a +1 within the pregnancy, within the birthing room, and they wanted to make sure that they were also going to be the +1 if that has been the person who's been advocating for them, and that they were also allowed to be in the room when a person is giving birth. In those provisions in Section 43, and then it continues on conforming language in different chapters, is the inclusion of Section 44, which is making sure that testosterone replacement therapy is included within insurance for menopausal women. And that continues to go through the bill regardless if it's an HMO, MCO, etc. And so with that, I will open up for questions.
Thank you, Senator. Thank you for your presentation. Okay, just one second. I do have a question as we begin. I just want clarification with regard to the sections that we're deleting out of this measure. Senator, Section 26 is pretty robust, and I just want to make sure that we're not deleting anything that we shouldn't in this conversation. On page, so I'm also on the second reprint. I have page 12 is where Section 26 starts.
That is correct.
And then are we deleting everything until page 18 up to Section 29?
That was my intent when I did the finance hearing. And so I'm working it out with Ms. O'Grady to make sure that this replacement language wasn't existing statutory provisions, that they, or somehow there was some form of miscommunication. Because when I submitted the amendment in finance, it was delete Section 26 in entirety, because that was an agreement that I had made with other stakeholders. And so that's where I'm at. But I'm trying to talk with legal to make sure that we're on the same page and that this amendment actually has caught up with the hearing that I just had last week.
Thank you, Senator, for that clarification. That will help us as we try to consider how do we move the bill forward today. So I thank you for that clarification. We do have a couple of questions. We'll start with Assemblymember Edgeworth.
Thank you. Thank you for bringing this bill. It does have a lot of things that could help a lot of people. My question is, we talked a little bit about the EKG. I too have received some information from people a little in opposition. I think we're talking about Section 19 where you're requiring EKGs, and I think what the things that I'm aware of, and I wish that you would speak to why what made you decide to include this is some people are actually in opposition to doing random screenings. The American Heart Association and the USPSTF have specifically said that they don't feel that there's evidence to support that. So my question to you would be, what was there other evidence that led you to want to include that?
Thank you for the question. I'm going to turn this over to Mr. Rock, and then I will add in.
Thank you, Mr. Rock. Go ahead whenever you're ready.
Okay. Good afternoon. Can you hear me?
Yes, please state and spell your name for the record, and then you can begin. Thank you.
Good afternoon, Madam Chair, Senator Neal, members of the committee. My name is Troy Rock, Roques, and I'm the Executive Director for Vegas for Athletes. Were there questions for me, or am I just supposed to speak?
We had a question for you, Assembly Member. Would you repeat the question for him, please?
Absolutely. Thank you so much for being here. My question is that there has been some opposition to requiring an EKG for all student athletes when there are recommendations by people far smarter than I am, like the American Heart Association and the USPSTF, who have specifically weighed in saying that they don't feel that there's evidence to support that testing.
I can only say that, again, referring to the American Heart Association, they also
Would you
say
state,
that,
I'm sorry, every time you
there-
talk, you have to state your name for the record, if you don't mind, Mr. Rock. Thank you so much.
Sure. Troy Rock, Roques. In response to the question, the American Heart Association also states that there are 365,000 out-of-hospital cardiac arrests in the United States. Nearly 90% of them are fatal. And even more alarming, 39% of sudden cardiac arrests in youth under 18 are sports related. So here in Las Vegas, since last year, we've screened 635 local student athletes. We found 16 with heart abnormalities and 7 with life-threatening conditions, with the results confirmed by Dr. Sampson from the Nevada Children's Heart Center.
Thank you.
Thank you. Any other questions, members? Nope. Oh, Assembly Member Koenig, thank you.
Thank you, Chair, and thank you, Senator, for bringing this forward. I'm tired enough. I'm not sure I have the energy to even ask this question at this point, but my question has to do in Section 29 when we're talking about the race-based care standards. Actually, at this point, I'm glad I'm not a nurse and would have to keep track of all these different race regulations, these race-based care standards. But, I mean, just in my personal experience in dealing with eyes, I mean, there's different diseases that are way higher in certain populations, and a lot of treatments has to do with how much pigment is in the eyes, and some races are going to have a lot more pigment in their eyes, so you treat them different ways. I don't know that, I think it's kind of complicated and confusing to have to take consideration of race out of that. I mean, there's definitely certain diseases that are way higher in the Asian population, and some that are higher in different races, and so to have to not be able to apply race based health formulas, I'm not sure that's for the best. Maybe if you could just touch on that for a minute.
So, Senator Neal, for the record, so I just want to make 2 points. First point to Assemblymember Edgeworth. If you look at National Institutes of Health, there is, because I had to pull it up because I closed my screen, there is actually a study related to the active surveillance of sudden cardiac death in young athletes. There is also a study from AHA and ASA journals on the sudden cardiac death for the Collegiate Athletics Association of Students, and it's a 20-year study. Talks about the benefits, and it talks about the what could also be the challenges. So getting to Assemblymember Koenig's question, it doesn't completely eliminate race. It's saying that race it tries to have a race neutral formula that should be examined, and having a mechanism in the language where if there is an update to the science, that within a year you must also update what you understand and know to be about the changes, right? So I really want Dr. Bayo to weigh in on this, because she is the national expert and this is like her space. I believe she's on the phone.
I do believe
Hello.
that. There she, go
I
ahead.
apologize. Hello.
Dr.
Hi,
Bayo,
this
go
is,
ahead. Thank
Dr.
you.
Bayo Curry. Oh, perfect. This is Dr. Bayo Curry Winchell. I'm a family medicine physician and a nationally recognized health advocate. I apologize. I just need to clear my throat. I am so sorry. So I'm so excited to talk about this question about race-based healthcare, and I'm so grateful for Senator Neal to highlight the importance of this. I first would love to, and I apologize, I did not hear the senator's name who addressed, race and its role in health. So what I'd love to do is kind of share the definition, because I think it'll help kind of provide information for everyone listening right now to understand why race should not be the go-to when it comes to delivering healthcare. Race is actually, the definition is the color of someone's skin, meaning it's a social construct. It's something that humans made up. And so to utilize the color of someone's skin to make the decision on what type of care that should be given, what type of medicine should be given, is actually harmful. And I'd like to kind of give more information on that. When we talk about genetics, and I like to use myself as an example, I am a Black woman and I'm a physician, but that does not mean that I am African. And so the color of my skin does not indicate my genetics. And currently right now, there are several tests, exactly what Senator Neal mentioned. There's a pulmonary function test, and there's also a medication that I'll share with you that is that a lot of you probably either know someone that's on or may be on yourself, which is a blood pressure medication that is recommended to Black individuals just solely based on the color of their skin. There's a UCSF study, which I know she has, and I can share it with everybody, that showed that race-based healthcare or race-based delivery should not be a part of healthcare. So I'm going to give an example. Currently, right now, as the senator mentioned, the other senator, that there's certain diseases that are thought that are more prone in certain races. Well, the issue is the color of someone's skin is not where that disease lies. The disease lies in the genetics. And so right now, if you have high blood pressure, there are two recommended classes of blood pressure medication for individuals who are Black, meaning if you just have this color, the skin color being Black. Why is that a problem? So if I come in as a patient and I'm Black and I'm offered only two classes of high blood pressure based on the color of my skin, I am not offered all of the other high blood pressure medications that could actually work to control my blood pressure. Historically, we have all heard that certain races, including Black individuals, have a higher risk of developing high blood pressure. Well, that study was based solely on the color of people's skin versus their genetics. And if you are limited to two types of high blood pressure medications solely based on what you look like, of course, your blood pressure may not be controlled as quickly or as efficiently as someone who any other race gets all of the other blood pressure medications. And when we look at the fact that Black individuals are dying at the highest rate from kidney disease, and how do you get kidney disease? Uncontrolled high blood pressure. But if you're only given
2 classes of blood pressure medication based on what you look like, not your genetics. It is a full circle. So I'd like to highlight why the importance of removing race as the indicator for what type of medication you get should not play a role. It should be based on that individual. It should be based on genetics, not solely the color of my skin. Thank you.
Thank you for your comments. Thank you. Members, any other questions? Okay, seeing no questions. Thank you, Senator, for being here. We appreciate you. Thank you. We'll ask you to go ahead and step back. This time we'll open up testimony in support of this measure. If you would like to offer testimony in support of Senate Bill 192, please come forward here in Carson City as well as in Las Vegas. You may begin when you're ready.
Good afternoon, Chair Brown May, members of the committee. For the record, Patricia Charlton, Chancellor, Nevada System of Higher Education. We want to thank Senator Neal for bringing forward this important legislation, and we recommend and urge your support of the bill.
Hello, Chair and Committee. Sheila Bray with the University of Nevada, Reno. We too are in full support. Section 65 lays out a specific area for study and report that the Senator has engaged both us and UNLV on, and we just thank her for including us, and we urge your support.
Thank you. Seeing no one else here in support in Carson City and there's someone at the table in Las Vegas. Go ahead.
Good afternoon, Madam Chair and members of the committee. I am Dr. Constance Brooks, Vice President for Government Community Engagement at the University of Nevada, Las Vegas. We are in support of this legislation. We also thank Senator Neal for her inclusion of UNLV and UNR in this legislation and the bill development. We also want to thank Senator Neal for her steadfast career as a legislator in infusing equity throughout the NRS and the fact that she is a champion for equity. As one of the most diverse institutions in the country, we are in support of this legislation and also look forward to our thriving medical school and our students having a role in seeing this legislation come to fruition. Thank you.
Thank you, Dr. Brooks. Seeing no one else here in support in Carson City or in Las Vegas, AVH will go to the telephone lines. Is there anyone here who would like to offer support testimony on Senate Bill 192?
To testify in support for Senate Bill 192, please press star 9 to take your place in the queue. Again, if you wish to testify in support, please press star 9.
Eric Wilcox, ERICWILCOX. Thank you, Chair Brown May and members of the committee, and thank you also, Senator Neal, for bringing this bill to the legislature. I'm the parent of a deaf child and chair of the Nevada Commission for Persons Who Are Deaf and Hard of Hearing. The Deaf Commission routinely hears complaints from the community that we represent about difficulty obtaining adequate sign language interpreters in healthcare settings. There's an urgent need for renewed commitment to providing access to qualified interpreters, which are afforded to the deaf and hard of hearing individuals under the Americans with Disabilities Act, including during childbirth. Therefore, the Commission urges your support for Senate Bill 192. Thank you.
Good afternoon, Chair Brown May. This is Catherine Nielsen again, with the Executive Director of the Nevada Governor's Council on Developmental Disabilities. Senate Bill 192 promotes inclusive, accessible, and respectful birthing care for all Nevadans, especially those in the deaf and hard of hearing community. And far too often, deaf and hard of hearing individuals face barriers to communication during labor and delivery. Inaccessible or delayed communication can put both the parent and the baby at risk, and this bill helps address these gaps in reinforcing the need for consistent standards across all birthing settings, including freestanding birthing centers. This bill sends a powerful message that every Nevadan deserves access to safe, informed, and culturally competent care, regardless of their communication needs. And we submitted a longer piece of testimony for this measure that's available on Nellis. Thank you for your time and consideration.
Good afternoon, Madam Chair, members of the committee, Anna Marie Binder, for the record again. I just want to offer support and solidarity with Mr. Wilcox and Ms. Nielsen. Thank you.
Chair, the public lines are open and working. We have no more callers choosing to testify in support at this time.
Thank you, AVH. At this time, we'll move into opposition testimony. If there's anyone here who would like to offer testimony in opposition, please come forward here in Carson City or in Las Vegas. Seeing no movement in the room, AVH, is there anyone on the telephone line who would like to offer testimony in opposition on this measure?
To testify in opposition to Senate Bill 192, please press star 9 to take your place in the queue.
At this time, we'll move into testimony on neutral if you'd like to offer testimony on neutral on this measure. Oh,
Chair.
go ahead.
Hello. Sorry, I'm Chair and members of the Assembly Health and Human Services Committee. My name is Erin Bailey. I'm with the Nevada chapter of the American College of Cardiology. Today, we are testifying in opposition to Section 19 of Senate Bill 192, which our reading is to require EKG screening for student athletes in certain school districts. The American College of Cardiology scientific guidelines do not support mandatory EKG screenings for all athletes. Unfortunately, EKGs will not detect all underlying heart issues as intended. This means there will be many instances of false negatives or false positives, leading to unnecessary downstream testing, high healthcare costs, and unwarranted restriction from sports. As we've seen in the most recent nationalized and publicized sudden cardiac arrest, many of the athletes had been screened for years, and all of their screenings were normal. We are also concerned about the lack of infrastructure in the state to support this section. Unfortunately, we do not have enough qualified and trained healthcare providers who can distinguish between a normal response to athletic training seen on EKG and actual pathology. While we appreciate nonprofits and organizations that offer these tests around the state, you need a specific provider who is trained in reading these tests to thoroughly assess the results. The Nevada chapter of ACC worked hard this session on Assembly Bill 454, sponsored by Assemblymember Nadeem, to require cardiac response plans for all schools. While we appreciate the senator's intention, however, the best way to save our young athletes' lives is through emergency preparedness, with immediate AED access, trained individuals, and a well-established cardiac emergency action plan. Thank you.
Chair, we have no more callers for opposition at this time.
Thank you, AVH. At this time, we'll move into neutral testimony. If you'd like to offer testimony in neutral on this measure, please come forward here in Carson City or Las Vegas. Seeing none, AVH, is there anyone on the line who would like to offer testimony in neutral?
To testify in neutral to Senate Bill 192, please press star 9 to take your place in the queue. Chair, we have no callers for neutral.
Thank you, AVH. We'll invite our bill sponsor back up if you'd like to make closing comments. We're getting a no. Thank you, Senator Neal. We'll officially close the bill hearing on Senate Bill 192, and thank you very much for being with us. That'll move us to the next measure on our agenda, and we will welcome up Senator Pizzina and open the bill hearing on Senate Bill 262. Senator, you were not here with us earlier. We are asking for concise presentations, and then we can move into questions. Thank you.
Good afternoon, Chair Brown May, Vice Chair Wynn, and Assembly Committee on Health and Human Services. My name is Julie Pizzina for the record. It's good to see you all again, and I do plan to be brief today. However, while my remarks will be brief, I also have 2 minutes each from deans at UNR and UNLV medical schools because I feel that is really important when it comes to this topic. So I'll begin with some context regarding the bill. According to the American Association of Medical Colleges, Nevada ranks among the lowest states in the nation concerning the ratio of active physicians per capita, with about, and I'm going to repeat this, 218 physicians for 100,000 people. Again, 218 physicians for 100,000 people compared to the national average of 272. Research published by the Nevada Health Workforce Research Center highlighted that about 70% of the state's population live in areas with a shortage of primary care providers. I can summarize the bill for you, but just to conserve on time, and Chair, I'd be happy to, or Vice Chair, I'd be happy to if you'd like me to, but I'm going to discuss the proposed amendment because I feel like that might be more important right now since time is of the essence. To briefly walk you through some of the amendment, institutions must be approved by the Nevada Hospital Association and DHHS to eliminate or reduce the size of their residency or postdoctoral fellowship programs. Such institutions seeking approval must submit a detailed application regarding their service area, and institutions that reduce their size without approval could face penalties. As many of you know, we had a program close in the rurals not too long ago, so this is to avoid situations like that happening again, especially in our critical care areas. The program is encouraged to seek out ways to use federal financial participation in Medicaid to support medical residency and postdoctoral fellows in Nevada, and language outlining how DHHS may award grants and consider recommendations from the Advisory Council on graduate medical education to prioritizing award grants in certain circumstances. This is not a money committee, but I will say that the fiscal note has been removed. There is, however, an appropriation ask on this bill of $9 million, which was very similar to what the governor had requested at $8.5 million for graduate medical education. And to give you an idea of the cost of programming, just per year, an OBGYN residency startup is about $2.8 million a year. So just to give you an idea of why this money is so important. I would be happy to answer more questions in a moment, but I'd love to pass it over to our phenomenal deans I'm going to start with UNR, Dr. Philip Clark, and then after he speaks, we'll go to Dr. Kate Martin in Las Vegas.
For the record, Dr. Philip Clark, Senior Associate Dean of Administration and Finance at the University of Nevada, Reno. Madam Chair, members of the committee, thank you for letting me speak. The University of Nevada, Reno School of Medicine acknowledges the importance of securing essential funding to enhance graduate medical education within Nevada. Presently, Nevada exports a significant number of its medical students to residency programs in other states due to the limited availability of residency slots compared to the number of medical students graduating from our institutions. Consequently, the probability of these students returning to practice medicine in Nevada after completing their residencies elsewhere diminishes substantially. As a result, the economic advantages derived from investing in medical student education are being realized by other states that retain our residents within their workforce. To address this issue, it's imperative that we take steps to reverse this trend to prevent a continuous decline in our physician workforce. This investment is crucial in reversing the concerning trend of a declining physician-to-patient ratio, which poses challenges for our citizens in accessing the critical healthcare services they require. Thank you.
Thank you so much, and we're going to move to Las Vegas and Dr. Martin.
Thank you. Honorable Chair and committee members, good afternoon. My name is Kate Martin, K-A-T-E-M-A-R-T-I-N, and I'm the Associate Dean for Graduate Medical Education and a Family Medicine Physician at the Kirk Kerkorian School of Medicine at UNLV. As someone deeply involved in medical education and healthcare delivery in Nevada, I am privileged to witness firsthand both the challenges and the potential of our healthcare system. I'm here today to speak in strong support of Senate Bill 262, which addresses a critical issue, the shortage of residency and fellowship programs in Nevada. This bill provides a crucial framework for expanding these programs across a broad range of specialties and subspecialties, including those that are currently underrepresented in our state, such as ophthalmology, dermatology, and surgical oncology. In particular, Section 3 of this bill will facilitate funding opportunities for these expansions, directly supporting the creation of additional training slots in high-need areas. As a result, Senate Bill 262 will improve the ability of Nevada's healthcare system to train and retain the healthcare providers we so desperately need. By fostering the expansion of these programs, the bill directly addresses our state's ongoing healthcare workforce shortage. As a physician, I see the challenges that Nevadans face in accessing timely specialty care. With our state's physician shortage, patients often endure months-long wait lists for specialty appointments. While Nevada has made strides in expanding graduate medical education programs, we still rank 41st for the number of residency and fellowship positions available. In fact, in 2023, only 47.2% of GME graduates remained in Nevada to begin clinical practice or continue training. Of those who left, nearly half left to pursue subspecialty training not available in the state. When subspecialties are not represented, this forces our medical residents to seek opportunities elsewhere. Students who complete both medical school and graduate medical education in Nevada have an 80% statistical chance of staying in the state. But without key fellowship programs, we will continue to see many medical residents leave for training elsewhere. Senate Bill 262 presents a critical opportunity to address these disparities by expanding residency and fellowship programs in a wide variety of specialties. This bill directly supports these efforts by creating avenues for broader funding and program development, as outlined in Section 3, which will not only improve access to specialty care for Nevada residents, but also increase the likelihood of retaining our homegrown talent. We're interested in how this bill can support the expansion of healthcare services in rural areas in particular, and how UNLV can be helpful in that regard. I urge your support for Senate Bill 262, which will help ensure Nevada's healthcare system has the capacity to meet the needs of its growing population and retain the physicians trained within our state. Thank you for your consideration.
Thank you so much to both deans for being here today. And the last thing I'll say before we open up for questions is, like everyone in this room, we knock on doors, we talk to our constituents, and we ask what matters to them. And what I heard resoundingly was healthcare. Either my spouse, my child, my parent, I can't get into a doctor. And I had people literally crying on their doorsteps because this is such a challenge, accessible healthcare. And that's what this bill is aimed to help with. So with that, I thank you so much for your time, for allowing us the hearing today, and we're ready to stand for questions.
Thank you, Senator. Members, are there questions? Assemblymember Hafen.
Thank you, Chair. I'd just like to actually disclose that my brother runs the anesthesia residency program at UNLV. He is an unpaid professor over there, I guess. I don't know the technical term. Clearly, I don't. But I did want to disclose that on the record, so there is no financial benefit to him or my family, so I will be participating in this item. Thank you.
Thank you for that disclosure. Thank you. Members, any other questions? No, thank you. I think we've spent a fair bit of time on this issue in particular. Do you have a question? No questions. Okay, thank you. So thank you for the presentation. If you'll step back, we will open up testimony in support of this measure. Again, I will encourage you, expediency, dittos are great. We do have a couple of other bills right here, and we're going to play beat the clock this afternoon. So please feel free to begin when you're ready. Thank you.
Thank you, Chair Brown May, and members of the committee. For the record, Patricia Charlton, Chancellor, Nevada System of Higher Education. I will be very, very brief. Obviously, graduate medical education is absolutely critical to our two medical schools within the system, and so just want to very much urge your support and thank the sponsor for the bill.
Good afternoon, Chair Brown May and members of the committee. My name is Mitchell Anderson, and I'm a soon-to-be third-year medical student here at UNR. Before medical school, I joined the National Guard and served as a firefighter here for over a decade, while also working on the ambulance here in Reno since 2015. I chose this path because I wanted to serve, not just in the military, but directly within the Northern Nevada community. I've been fortunate enough to stay rooted here throughout both my education and my service. Between the Guard, my years at REMSA, and my time at the Student Outreach Clinic during medical school, I spent the better part of my adult life caring for members of this community. To this day, I still work shifts at REMSA because I genuinely love the work and the colleagues I'm lucky to work alongside. But despite all of the roots I've been able to establish here, I'll likely have to leave once I graduate. And not because I want to, but because there simply aren't enough residency or fellowship opportunities here in my area of interest. And I'm not alone. Many of my classmates are facing the same reality. And that's why this bill is so important. The AAMC reports that 48% of physicians stay in the state where they do complete residency, and that number jumps tremendously when they attend both medical school and residency in the same state, as you've heard before. Yet Nevada currently ranks 41st in the country for residents and fellows per 100,000 people. We are training far fewer physicians than we need. Expanding graduate medical education doesn't just address the provider shortage, it also strengthens the entire medical education pipeline. Residents are expected to conduct research, which would open the door for medical students to get involved locally instead of having to leave over the summer and go out of state. It also creates mentorship opportunities that shape the kind of doctors we become. More physicians trained in Nevada means stronger continuity of care, deeper community ties, and better outcomes for our patients. This expansion isn't just about training physicians, it's about retaining them, improving care, and protecting the future of healthcare in our state. Thank you for your time.
Good afternoon. My name's Patrick Kelly with the Nevada Hospital Association. We have serious workforce shortages in healthcare in this state, and physicians are no exception. We need primary care physicians, specialists, you name it. And so this bill will move us in that direction. Thank you.
Thank you, Chair and members of the committee. Blaine Osborne, Nevada Rural Hospital Partners, for the record. Happy to be here in support of this bill. Really want to thank Senator Pezzina for continuing to be a champion of GME for us, and we support the amendment as well. Thank you.
Hello, my name is Allison Gunderson, ALLISONGUNDERSON. I'm a rising third-year medical student here in support of SB 262. I wanted to share my personal story because I think I'm in a unique position. I desire to become an OBGYN with specialization in fertility, and as of today, if I'm pursuing those career goals, that would mean me leaving Reno for 7 years. In those 7 years, it's a long road, and I would expect to start a family and set down my roots, and unfortunately, most likely, I'll have to be out of state for that. And when you set down those roots, it's harder and harder to walk away from the community. So what I would desire is a path to stay at home, serve the Reno community, and I believe that SB 262 is a way to support that. An OBGYN program is already in the works for 2026, and I may get the opportunity to stay as long as the program gets adequate financial support it needs. So the more we invest in in-state residency programs, the more we create opportunities for homegrown physicians to stay and train right where they started. Thank you.
Good afternoon, Chair Brown May, members of the committee. For the record, my name is Nick Schneider, Director of Government Affairs for the Vegas Chamber. For the sake of brevity, we're also in very strong support of SB 262. This is also, and historically has been, a Southern Nevada forum priority, so I'd love to see this coming through. Thank you so much.
Good afternoon, Chair and Committee. My name is Sabrina Schnur, SABRINA, SCHNUR, and I'm here today on behalf of the Nevada Public Health Association and the Nevada Primary Care Association, which is the state's federally qualified health centers. NVPCA appreciates that this maximizes federal resources for the benefit of underserved communities, and also want to note that Arizona and New Mexico have used a similar policy to develop primary care residencies in their community health centers, and we think this will be a great model for Nevada. Thank you to Senator Pezzina.
Thank you, Madam Chair, members of the committee. Allison Herzik, Director of Nevada Government Relations for Dignity Health St. Rose Dominican. We are in full support, and we want to thank Senator Pezzina for her work on this. Thank you.
Good afternoon, Chair, members of the committee. My name is Chris Bosse, BOSSE, for the record, Chief Government Relations Officer for Renown Health. We want to also thank the Senator for her leadership on this important bill that will provide much-needed resources to GME programs like the one at Renown Regional to expand the key training programs that we currently do not have, and we're looking forward to doing that with our affiliate partner, UNR Med. Echo many of the comments that others have made. We encourage your support of SB 262. Thank you.
Madam Chair, Dan Musgrove with Strategy 360 here today on behalf of two of my clients, the Valley Health System of Hospitals and U.S. Anesthesia Partners, in which Dr. Hafen is our program director of a residency program that is actually sponsored by our competitor HCA. And it's that important that hospitals believe in these resident programs that they a lot of times fund them themselves. So we would appreciate when we can do further expansion of our own GME and support. And so thankful for Senator Pezzina on carrying the load on this. Thank you.
Thank you. Seeing no other support up here in Carson City, we'll go down to Las Vegas. You may begin when you're ready.
Madam Chair, members of the committee, good afternoon. Dr. Constance Brooks, representing the University of Nevada, Las Vegas. I echo all the sentiments that were said prior to my testimony. We also want to thank the Senator for her tenacity in bringing this forward for a second session for GME to be addressed. It's a critical issue in our state, and we certainly appreciate her advocacy and leadership, as well as her inclusive nature in developing the bill, including both the UNR and UNLV schools of medicine and our leadership. Thank you very much.
Good afternoon, Madam Chair Brown May, esteemed committee members. I'm Dr. Wolfgang Gilliar, WOLFGANG-GILLIAR, in my capacity as Dean of the College of Medicine of Touro University, Nevada. Here in Henderson, I am both honored and pleased to testify in support of SB 262. I will stray a little bit because it's not just quote on my professional side, but on the personal side. And let me start with the personal side. When Touro hired me and lured me from the cold New York, where I was dean, to here, It was Shirley Berkeley who looked me in the face and said, we actually are looking for an advanced, forward-looking dean who really brings academics to a new level. But more, we need a dean who will facilitate everything possible to bring healthcare to the state and grow our own people here for the state. I heard that message loud and clear, and SB 262 with its revision clearly reflects the state's dedication to enhancing and enlarging tangible graduate medical education. Furthermore, embedding GME within the broader context of healthcare workforce strategy discussions, to me, is a meaningful forward step, and thank you, Senator Pacina, for including all of the stakeholders. As you know, Touro, Nevada is one of now 4 medical schools in this wonderful state of Silver State of Nevada. 2 are public, UNR and UNLV, and 2 are private, non-profit medical schools. And I really think that coming together, we can do this. What drives all of the medical schools forward is the next step together after graduating, caring, competent, and confident doctors. But more, and I would like to emphasize this, if prospective students who are considering to go to medical school, especially those who come from Nevada and surrounding states, if they know they have an entire product, the medical school and residency here in place, we can really attract the best, the most highly competitive students. And I would like, and I have this pipe dream perhaps, but then again, pipe dreams happen in Nevada because we have now a hockey team that plays ice hockey in the desert. We have a team that plays football that nobody thought would ever happen. At this juncture, I really think we should make this a real study of how we can come together as a community to distribute the healthcare so that everybody can benefit from it. We need to move from a desert to a vital oasis.
Thank you
We need
so
to change
much.
this
Thank
together.
you.
And
Thank
thank
you.
you for being able to bring this testimony to you in the hope of just knowing that we have, and please take this home. In my opinion, I've been a medical educator for many years. I believe that this, and I believe it because I see it, this generation of medical students is the best I've ever educated. They're dedicated, they're motivated, they're in for it for the greater good. And I really think we have an absolute opportunity for us to be in Nevada a showcase rather than somebody lagging at 41.
Thank you, Dean. Thank you so much. Thank you for being here and your comments. We appreciate you. Is there anyone else in support in Las Vegas? Thank you. Okay, thank you so much. All right, AVH, seeing no one else here in person, we'll go to the telephone lines. Is there anyone here who would like to offer comments in support?
Testify in support for Senate Bill 262. Please press star 9 to take your place in the queue.
Good afternoon, Chair Brown May and members of Assembly HHS. My name is Damon Schilling, SCHILLING, and I am the Director of Government Relations for Intermountain Health here in Nevada. I would like to echo the sentiments of everything that has been said before me. It is a great opportunity to keep Nevada heroes here in Nevada, to provide for our citizens and to provide hope and opportunity that doesn't currently exist. And I would also like to bring up something that hasn't been said yet, and that is we also provide other people with this program the opportunity to come and experience what we already know, and that is that Nevada is the best state you could live in. It is one of the best states you could reside in, to provide care in, to watch world-renowned hockey in, and we are very excited for this program. We congratulate and support Senator Pacina for taking the initiative to bring more GME to the state of Nevada. And we are very grateful for it, and we look forward to it with our Children's Hospital and urge you to support this bill. Thank you very much. Have a great day.
Good afternoon. This is Dr. Jeffrey Murawski, M-U-R-A-W-S-K-Y for the record, Chief Medical Officer of HC's Far West Division in the Sunrise Health GME Consortium. I'd like to thank Chair Brown May and the committee members for allowing me to speak in strong support of SB 262. I first want to thank Dr. Pazina, as been mentioned before, for all of her strong work and persistence in bringing this very important bill forward. As a provider of GME with 318 total resident positions and 140 of these in the primary care specialties, continued growth in both these core positions, but also, as mentioned before, in the more advanced specialties and subspecialty fellowships is needed to address the care gap that's been mentioned across the state. Keeping care local here in Nevada is critically important, and by keeping our physicians but providing opportunities to train post-medical education is critical to moving that forward. Again, we want to speak in strong support of this bill and all of the collaboration that's been done to bring it forward. Thank you.
Chair, the public lines are open and working. We have no more callers for support at this time.
Thank you, AVH. At this time, we'll move into opposition. If you would like to offer testimony in opposition on this measure, please come forward here in Carson City or Las Vegas. Seeing no movement, AVH, is there anyone who would like to offer testimony in opposition on this measure?
To testify in opposition to Senate Bill 262, please press star 9 to take your place in the queue. Chair, we have no callers for opposition at this time.
Thank you, AVH. At this time, we'll move into neutral testimony. If you would like to offer testimony in neutral on this measure, please come forward here in Carson City or Las Vegas. Seeing no movement toward the table. AVH, is there anyone on the telephone line who would like to offer testimony in neutral on this measure?
To testify in neutral to Senate Bill 262, please press star 9 to take your place in the queue. Chair, we have no callers for neutral.
Thank you. AVH will invite our bill sponsor back up. Closing comments? No, we're getting a no. Thank you. We'll officially close the bill hearing on Senate Bill 262. Thank you, Senator Pazina, for being with us today. That moves us to the next order of business we have. We'll open up the bill hearing for Senate Bill 497, and we'll invite Senator Wynn to the table. Thank you so much, Senator, for being here.
Thank you. Rochelle Wynn for the record, and I'm proudly presenting Senate Bill 497. For some of you that sit on Senate or on Assembly Ways and Means, this will be familiar. This is probably not a bill that you hear often in this policy committee, but this is a budget implementation / policy bill. During the closing of one of our subcommittee budgets, and ultimately what was closed in the budget that was sent over to for signature to fund our government, included some provisions regarding a bill that we had passed in 2021. In 2021, we almost unanimously, I believe unanimously, passed a Senate bill that created a unusual situation in our NRS. In this situation, it creates automatic increases for this one provider type. No other providers in this state receive automatic increases to their rates that they are able to receive, except for when it comes to the reimbursement rates for applied behavioral analysis services. This became very apparent while we were closing budgets. We were in a position, unfortunately, in our state where we are not able to expand a lot of services. We are not able to give a lot of increases. We are not able to do a lot of these things, unfortunately, in our state. However, when it came to this one particular group of community providers, we are locked in statute that they are to be given rates. So we did close the budget with the recommendation that this bill be brought. That's why it is a committee bill that is being brought here today to seek to remove that language from statute so we can address these community providers just like we do any other community providers when we are preparing our budget and funding our state. And I will stand ready to ask any questions you might have.
Thank you for that presentation. I appreciate that. Just one clarification, Senator. It's my understanding that our Division of Medicaid has a quadrennial rate review that's required for all of the rates that we offer in Medicaid. Is that correct? Is that your understanding?
That is correct. And this is the only providers that not only have that, but also have to seek an unusual thing where they can kind of seek out which is a good gig if you can get it, which they did in 2021, unfortunately, where they can seek out what the most successful comparable rate is across the entire country and say that is a comparable rate and that we should use that. So it tends to lead to automatic significant increases where we are always at the forefront of this, even in times where, like we are in this biennium and going forward with this budget, where we're not able to make those kind of determinations.
Thank you for that. Thank you for the clarification. Members, any questions on this measure? No, I'm getting a whole lot of shakes. That's really good. Thank you so much for the presentation. We'll open up testimony in support for Senate Bill 497. If you'd like to offer support testimony here in Carson City or Las Vegas, please come forward. Seeing no movement, AVH, is there anyone on the telephone line who would like to offer testimony in support of Senate Bill 497?
Testify in support for Senate Bill 497. Please press star 9 to take your place in the queue. Chair, we have no callers for support at this time.
Thank you, AVH. We'll move into opposition testimony. Is there anyone here who would like to offer testimony in opposition on this measure? Seeing no movement in Carson City and none in Las Vegas, AVH, is there anyone on the telephone line who would like to offer testimony in opposition?
To testify in opposition to Senate Bill 497, please press star 9 to take your place in the queue.
Good afternoon, Madam Chair, members of the committee, Anna Marie Binder again. I'm only in opposition in this individually. This actually was a huge conversation at the Commission on Autism Spectrum Disorder yesterday. And although we understand some of the benefits, just me individually, and I'm trying to get another meeting to get this on for you guys or not, but in our review of the 2025 quadrennial rate for the PT 85, which is the ABA therapist, what we really don't want to see was where we were years ago. So even this bill expands eligibility, which is very commendable and is very long overdue. It removes a statutory safeguard that has helped ensure ABA reimbursement rates remain somewhat aligned with national norms. Given the findings in the 2025 quadrennial rate review, which flagged PT 85 as underfunded and inconsistently reviewed, this change may result in reduced oversight, delayed adjustments, and inadequate funding unless robust data collection and rate accountability are implemented. So I just want to point that out. I could have a much larger conversation about that, but as it stands today, individually, I am in opposition. Thank you.
Rebecca Raynoa, for the record, Raynoha. As I was going through, I'm a BCBA and own my own practice, so I know that inherently will cause bias. When I first got into this field and decided to own my own practice, it's to help kids. And as I'm in Medicaid and I'm looking at the rates and I'm looking at my overhead, and it's already very, very tight. I think my biggest concern with this bill is the fact that we're already not keeping up with relative rates on 97153 relative to cost of living in comparable states. We are approximately $2 below our nearest states, Delaware and Virginia. And similar to the previous person who spoke in opposition, I am concerned that if these rates stagnant, waiting for the next review, that providers will further go out. I've been very participatory during the most recent legislation across various bills, and something always brought up is, will this bill address the provider shortage? What you're doing today will probably further cause a shortage if the wages remain stagnant. Thank you.
Good afternoon, Madam Chair, members of the committee. Stephen Collins, for the record, did not thank you, I yield.
Chair, we have no more callers for opposition at this time.
Thank you, AVH. At this time, we'll move into neutral testimony. Is there anyone here who would like to offer testimony in neutral on this measure? Seeing no movement here in Carson City and none in Las Vegas. AVH, is there anyone on the telephone line who would like to offer testimony in neutral?
To testify in neutral to Senate Bill 497, please press star 9 to take your place in the queue. Chair, we have no callers for neutral.
Thank you, AVH. We'll invite our bill sponsor back if she would like to know. We're getting a no for closing comments. Thank you. We'll close the bill hearing on Senate Bill 497. Thank you, Senator Nguyen, for being here. That will move us to the next order of business, and we will open the bill hearing for Senate Bill 54. Thank you so much. Welcome to Mr. Shaver, and you may begin whenever you're ready.
Thank you so much, Madam Chair, members of the committee. For the record, Dylan Shaver of Pinion Public Affairs here today on behalf of the City of Las Vegas. Joining me today to keep me out of trouble will be Kelly Crompton from the City of Las Vegas, and then Deputy City Manager Sabra Newby down in Southern Nevada. Very quickly today, we do have a very long PowerPoint that I'm going to spare you, but it is on Nellis. The chair was very clear that she would just kill the bill if we tried to present. So I will do my best to be very quick for you. This bill is a bill to establish basically a Medicaid code for medical respite care and to set the standards for that care. The genesis is a facility the City of Las Vegas opened during the pandemic. It provides services to the unsheltered population who have been discharged from hospital care or other intensive situations to provide stabilization services. This is a population who, when they are discharged, maybe in a way that you or I would recover at home, surrounded by loved ones who can take care of us. These are people discharged to the streets, and while they are there, their situations could get worse, and they would end up back in the hospitals, back in the ER. So during the pandemic, the city opened this facility. It is a 40-bed facility to just help people stabilize. The team will talk more about that. What the bill itself does is it requires Medicaid in Section 1, Sub 3 to apply for a waiver from the federal government to include this coverage in the state Medicaid plan. Sections 2 and 3 define this type of care, medical respite care, and put some guardrails on the kind of facilities that can offer it. And then Section 4 allows DHCFP to establish the standards of care for the patients that we bring in. We believe it will be a long-term money saver for the state, and it will allow for critical support of not just the City of Las Vegas facility, but any facility that can meet the standards of care DHCFP sets forth. With that concludes my remarks, Madam Chair. The Deputy City Manager, I think, would like to say a few words about the facility itself, and I think we can keep it pretty short for you.
Thank you very much. Please go right ahead.
Thank you, Chairwoman Brown-May. This is Sabra Newby, Deputy City Manager for the City of Las Vegas. Thank you for hearing this bill today. To date, since we've been open in 2020, we have seen over 1,100 patients at our recuperative care center. And we have remarkable results. The average stay is about 58 days, and upon leaving, because we have that time with these patients, we are able to house about 52% of those upon their leaving of the facility. We are constantly full, always getting new patients in and processing patients out. And we really believe it is a service that's not only humane for our citizens, but also ultimately saves the state money in reducing the time and times that these individuals come back into care, sometimes emergency care, which of course then costs more in Medicaid. This is not a new thing in our country. Actually, there's a number of states that have this waiver, including California, New York, North Carolina, and Washington. There's a number of other states that have put in application or are currently in the waiver approval process, and we are seeking to begin that process in the state of Nevada as well. I know it's been a long day for you, so I'm going to conclude my remarks there, but I'd be happy to answer any questions you might have.
Thank you, Madam Chair. Kelly Crompton, representing the City of Las Vegas. We'd just like to take a moment to thank those legislators that have come to the RCC, toured the facility, asked questions throughout the interim. We welcome any of the new legislators that are on this committee or any committee to come and tour that in the interim. And we'd also like to make sure that we thank Administrator Stacy Weeks for all the work that she has done to help us on this bill and work with us. Thank you. And we're open for questions.
Thank you for your presentation. Thank you all for being here. It is truly a remarkable experience to go and tour the facility and see the work that's being done. So I'd really admire how far this has come, and congratulations on all the work. It's also really great to see our former colleague here who is now in a new capacity. So thank you, former Assembly Member Newby, for being here. Members, are there any questions? Assemblymember Koenig.
Thank you, Chair. So in Section 1, subsection 5, I think we're talking definitions, says medical respite care, and it says for those who are experiencing homelessness. So we're making the definition for medical respite care has to do with someone being homeless. Does that term not exist already where it doesn't refer homeless people? I mean, the term medical respite care, if you look at that, you're not going to automatically think, well, that only, applies to homeless people.
Thank you so much for the question. Madam Chair, to you and the committee, Dylan Shaver for the record. Medical respite care is defined nationally as a service for the homeless in the current situation it stands right now. These are services that a typical patient would sort of receive in kind of other capacities. So this is very narrowly defined to this population.
Thank you. Members, any other questions? Okay, well done. Thank you for your presentation. We'll ask you to step back and we'll open up testimony and support. Again, I will remind you brevity is appreciated this afternoon. We still have 2 bill hearings to get to. Feel free to state and spell your name for the record. You may begin when you're ready.
Good afternoon again, Chair and Committee. My name is still Sabrina Schnur, Sabrina, Schnur, and this time just the Nevada Primary Care Association, which is the state's FQHCs. We're proud of our members that partner with the city in this project, and we are in full support. Thank you.
Madam Chair, Dan Musgrove on behalf of the Valley Health System of Hospitals. This is a crucial program. The average length of stay in an acute care hospital is anywhere between 5 and 7 days. That's about the average. And normally a person would then be released and go home and receive care there. Obviously, these folks don't have a home. They're homeless. They're unhoused. And so we appreciate what local governments are doing in stepping up and taking on this very important issue and problem. And we support this bill very, very much. And thank you for your support.
Good afternoon, Chair Brown-May, members of the committee. For the record, my name is Cadence Matijevich, Cadenceematijevich, representing Washoe County, here in support of Senate Bill 54. We commend the City of Las Vegas for the work that they've done here and for bringing this bill forward. We urge your support.
Good afternoon, Chair Brown-May, members of the committee, Gabrielle McGregor, GABRIELE, MCGREGOR, with the Ferrara Group, here today on behalf of Silver Summit Health Plan. Delivery of services to the unhoused population is a priority for the state in our Medicaid contracts, and we support this legislation because it will increase access to services for this population. Thank you.
Chair Brown-May, members of the committee, Allison Herzig, Director of Nevada Government Relations for Dignity Health St. Rose Dominican. I'll just ditto the comments made by Mr. Musgrove, and we are in support. Thank you.
Okay, thank you. Seeing no one else here in support up in Carson City and no one in Las Vegas, ABH, is there anyone on the telephone line who would like to offer support for this measure?
To testify in support for Senate Bill 54, please press *9 to take your place in the queue. Chair, we have no callers for support at this time.
Thank you, ABH. At this time, we'll move into opposition. Is there anyone here who would like to offer testimony in opposition on this measure? Please come forward here in Carson City or Las Vegas. Seeing no movement, ABH, is there anyone on the telephone line who would like to offer testimony in opposition?
To testify in opposition to Senate Bill 54, please press *9 to take your place in the queue.
Good afternoon, Madam Chair, members of the committee, Anna Marie Binder, for the record again, individually. I deeply respect the intent behind this legislation, acknowledging the acute medical and behavioral needs of individuals experiencing homelessness, but I have grave concerns about the state's continued reliance on short-term episodic care models as a substitute for long-term community-based solutions. Respite care, even at 30 to 60 days, is not a sustainable or appropriate response for individuals with complex behavioral health conditions. Many of the people this bill is intended to help are not simply recovering from a medical procedure or short illness. They are navigating layered needs related to untreated mental illness, trauma, substance use, and disability. These are not conditions that resolve in 2 months. They require continuity, case management, peer support, and housing stability, not just a bed and discharge summary. It's also worth noting that this bill relies on future federal financial participation and a still undefined waiver process. That means implementation is several years out, and even then, success will hinge on how Nevada structures its care model. Without clear, codified expectations for follow-up services, behavioral health access, and interagency coordination, this bill may inadvertently institutionalize people in short-term beds with no exit plan. Thank you.
Chair, we have no more callers for opposition at this time.
Thank you. We'll move into neutral testimony at this time. If there's anybody here who would like to offer testimony in neutral on this measure, please come forward. Seeing no movement here or in Las Vegas. AVH, is there anyone on the telephone line who would like to offer testimony in neutral?
To testify in neutral to Senate Bill 54, please press star 9 to take your place in the queue. Chair, we have no callers for neutral.
Thank you. We'll invite our bill sponsor back up if you'd like to make closing comments. Thank you. We're getting a no, so we will officially close the bill hearing on Senate Bill 54. Thank you so much for being with us today. And the next order of business, we will open the bill hearing on Senate Bill 329 and welcome Senator Flores to the table. Thank you, Senator. I know that you weren't here at the beginning. We are asking for brevity if at all possible. We do have to be on floor hypothetically in like less than a half an hour, and we still have a work session and another bill.
Thank you, and absolutely getting that cue, and I am good to go, Madam Chair, I promise you. Senator Edgar Flores, for the record, good afternoon, Chair, Vice Chair, and esteemed colleagues. For brevity purposes, I will not go through prepared remarks and only say that I have a subject matter expert that I've had an opportunity to work with, and I wanted to let you know that the version of the bill you see now is how we got to it through a lot of negotiations to get some of the opposition to move away from it. And I believe that we are now in a place where we have everybody either in neutral or support. And with that, I'll hand it over to Mr. Challenor.
Thank you, Senator. Ben Challenor for the record, Director of Public Policy for the Alzheimer's Association. Thank you, Chair. Thank you, Vice Chair and members. I'll try to be brief. This bill looks to authorize the different boards of health to make sure that they're able to require some sort of training for those who are living with cognitive impairment. The important piece that's I think we made sure to include in this is that it's not a separate training. It will be incorporated into what they're already currently doing. So making sure that we're able to work with those who are already on the ground working, and specifically for those who are EMTs, advanced EMTs, and paramedics. That's what this bill was ended up, the scope was narrowed to in the previous House, making sure that we're able to incorporate their current training with training for those on identifying and de-escalation for those with cognitive impairment. And so it's important to note that it's not a new separate training, just making sure that we're able to work with them to find somewhere where we could make sure we're including that.
Thank you. That was a great presentation. I appreciate that, and really appreciate your work on this, and understand it's an issue area that you're passionate about. So I appreciate all of the work that's been done to bring you to where you are, to build support on this measure. Members, are there any questions? Wow. Okay, that's wonderful. Okay, thank you for your presentation. We'll ask you to step back. At this time, we'll open up testimony and support on Senate Bill 329. If you'd like to offer testimony and support, please come forward at this time. Seeing no movement here. AVH, is there anyone on the telephone line who would like to offer support for Senate Bill 329? Oh, we have support here. Thank you. Thank you. I'm sorry, I moved too quickly.
Good afternoon, Chairwoman Brown May. For the record, my name is Maria Moore, M-A-R-I-A-M-O-O-R-E. And on behalf of ARP, we'd like to offer support for Senate Bill 329. I'll make my remarks brief. We know that first responders are often the first ones that are on the scene, and we urge that training be provided. We know that other states recognize the importance of such training, and that by passing SB 329, Nevada will join these proactive states in ensuring that first responders possess the necessary knowledge and skills to assist individuals with dementia effectively. This legislation not only promotes the safety and dignity of our seniors, but also supports first responders by providing them with the tools needed to navigate complex situations involving complex impairments. ARP Nevada urges the legislature to pass SB 329, demonstrating our state's commitment to protecting vulnerable populations and supporting our dedicated first responders. Thank you.
Thank you so much for being here. Did I hear a rumor that this will be one of your last testimonies, Ms. Moore? Is there a retirement in your future? Thank you. We'd like to congratulate you and thank you so much for being here with us. We appreciate all the work that you do on behalf of our population. Yes, thank you. AVH, we'll move into support. Is there anyone here who would like to offer support testimony online?
To testify in support for Senate Bill 329, please press star 9 to take your place in the queue.
Good afternoon, Madam Chair and members of the committee. Stephen Cohen for the record. Ditto. Thank you. I do.
Chair, we have no more callers for support at this time.
Thank you, AVH. At this time, we'll move into opposition testimony. Is there anyone here who would like to offer testimony in opposition on this measure? Okay, seeing no movement. AVH, anyone on the telephone lines who would like to offer testimony in opposition?
To testify in opposition to Senate Bill 329, please press star 9 to take your place in the queue.
Good afternoon, Madam Chair, members of the committee. This is Anna Marie Binder. Again, I actually raised, I think, super late in support and just echo and ditto all of that. I am a third generation who has made it to the year of 45 years of age without being diagnosed with early onset Alzheimer, and have held all of my ancestors' hands going into heaven as they deteriorated and suffered from Alzheimer and dementia. So I very much appreciate this initiative. Thank you.
Thank you. We'll move that into support testimony.
Chair, we have no callers for opposition at this time.
Thank you. We'll move into neutral testimony. Is there anyone who would like to offer testimony in neutral on this measure? No movement. Well, AVH, is there anyone who would like to offer testimony on the telephone lines in neutral?
To testify in neutral to Senate Bill 329, please press star 9 to take your place in the queue. Chair, we have no callers for neutral.
Thank you. AVH, at this time, we'll ask our bill sponsor if he'd like to make closing comments, and we're getting a no, a wave, and a no. Thank you so much for being here, Senator. We'll officially close the bill hearing for Senate Bill 329. That leads us to the last measure on our agenda before work session this afternoon, and we'll open the bill hearing on Senate Bill 424. We'll invite our presenters to the table.
Madam Chair, members of the committee, Alfredo Alonso today on behalf of the Nevada Ambulance Association. What you have before you is not new. these types of provider assessments have already been passed for providers and the hospitals in past years. The purpose of it is very basic. It's a mechanism in which the ambulance association members, which in this case, I think we have about 70,000 transports a year, so it's significant. We make up about 90% or 95% of the companies that are in this space, and the reimbursement rates are so low that, like others before us, this bill seeks to set a assessment. They assess themselves, comes out to about $20 per transaction or trip. That is then put into a fund or an account. Medicaid manages this account. And again, we've worked with Medicaid extensively on this to make sure that this is something that they could live with. That account then obviously goes to the feds, and the hope is that you get a match or at least a significant portion of money back, which helps these companies survive and by raising the reimbursement rates. The timing is critical. Obviously, there's many things happening at the federal level that we cannot control. The theory here is whether there's a moratorium on provider assessments in the future, or there is one now. It really doesn't matter. Our goal is to get this on the books and hope in the future that we'll be able to take advantage of this program. Obviously, at the federal government level, they could at any time remove this program altogether, and that's why it's so important that we do that now. I have Felicia Sis on, I think, the phone in case anyone has any technical questions, and I'm glad to answer any questions.
Madam Chair, members of the committee, Brian McAnallen, Vice President of the Nevada Ambulance Association. I just want to thank Senator Dunyate and the Senate Health and Human Services Committee for sponsoring this bill on our behalf. As Alfredo said, we are dealing with significant challenges in Medicaid reimbursement and the losses that we suffer. This program would help us mitigate those and get us closer to Medicare, not quite to what Medicare reimburses, but closer. And as was mentioned before, this program operates in a number of other states, so we're not doing anything that's new, and would appreciate your support today. Thank you.
Good. Thank you. Thank you for the presentation. We appreciate you. Stay right there. I think we have questions. Thank you. Assemblymember Golding, you have a question?
Yes, thank you. So if the program is canceled at the federal level, does that stop the self-assessment?
Madam Chair, to you and through you to Assemblymember Golding.
Please go
yes.
direct.
Yes, I mean, if the program stops or we're not paying into it or any of those things happen, then yes, it would cease to continue to collect. Yes. And again, the state's protected. If CMS says no, it's a no.
Thank you. Assemblymember Hibbets, do you have a question?
Thank you, Madam Chair. Just a quick clarifying question. I believe you answered, but I just want to get it on the record. So if feds turn off their spigot, the state is not liable to pick up that tab.
To Assemblymember Hibbets, that is correct.
Mr. Alonso, did you say your name for the record?
Alfredo Alonso, for the record.
Thank you, sir. I appreciate that. Thank you. Members, any other questions? Okay, seeing none, thank you for the presentation. This time we'll open up testimony in support. If you are here in support of this measure, please come forward at this time. Thanks so much. And thanks for waiting all day for this. Thank you.
Happy to be here. Good afternoon, Chair Brown May, and members of the committee. My name is Glenn Simpson, Simpson, Senior Director for Community Ambulance, which is a member of the Nevada Ambulance Association. Community Ambulance, we're currently facing higher costs with the same Medicaid reimbursements, which is an impossible business proposition. I'm here in strong support of Senate Bill 424. 424 would apply a uniform per transport assessment, allowing the state to draw down federal matching funds, bringing in $2 federal for every state dollar, and boost Medicaid payments without raising general taxes or cutting other services. With rising costs and flat Medicaid rates, companies like ourselves, which cover more than 65% of Clark County and respond to more than 350 911 calls daily, face an unsustainable gap. By implementing SB 424, we can strengthen Medicaid reimbursement for private EMS, help ensure timely access to life-saving care to Nevada communities, and leverage federal funds to support local services without increasing the burden on the state's general fund. Thank you for your support.
Madam Chair, Dan Musgrove on behalf of Medic West. To my colleague that was right next to me, I give a hearty and robust me too.
Good afternoon, Madam Chair, members of the committee. My name is Tom Clark, here on behalf of MedX Air One. MedX Air One is based in Elko. They also have facilities in Ely and Winnemucca. While they do not do the robust number of transports that you see in the urban areas, they do transport quite a few folks. In fact, because of their rural base, while MedX Air One is primarily a fixed-wing helicopter transporter, they will use the ground services because they're cheaper, especially when it's a Medicaid patient. We don't have the mental health beds in rural Nevada, so a lot of these Medicaid transports are for that purpose, not necessarily health issues, accidents, and that kind of thing. We look forward to participating in this program. We hope that this bill moves forward, and we very much support SB 424. Thank you, Madam Chair.
Good afternoon, Madam Chair and members of the committee. Lindsay Knox with McDonald Crono here representing REMSA. Ditto.
Okay, seeing no one else here in Carson City, we'll move down to Las Vegas. Go ahead when you're ready.
Madam Chair, committee members, for the record, Gary Milliken, Milliken, representing American Medical Response. We are also in favor of the bill.
Thank you. It's very nice to see you today. Okay, at this time we'll move into support. Thank you, Mr. Milliken. At this time we'll move in to AVH on the telephone line. Is there anyone here who would like to offer testimony in support of this measure?
To testify in support for Senate Bill 424, please press star 9 to take your place in the queue.
Good afternoon, Madam Chair, members of the committee, Anna Marie Binder again. I am in huge support, echo and ditto, and maybe we could get a hit star 2 if you're just calling in support option next session. That would be amazing.
That's a great suggestion. Thank you, AVH, if you were listening.
Chair, we have no more callers for support at this time.
Thank you. At this time, we'll move into opposition testimony. If you'd like to offer testimony in opposition, please come forward here in Carson City or Las Vegas. Seeing no movement, AVH, is there anyone on the telephone line who would like to offer testimony in opposition?
To testify in opposition to Senate Bill 424, please press star 9 to take your place in the queue. Chair, we have no callers for opposition at this time.
Thank you, AVH. At this time, we'll move into neutral testimony. If you'd like to offer testimony in neutral on this measure, please come forward. No movement here, no movement in Las Vegas. AVH, is there anyone on the telephone line who would like to offer testimony in neutral?
To testify in neutral to Senate Bill 424, please press star 9 to take your place in the queue. Chair, we have no callers for neutral.
Thank you, AVH. We'll invite our bill sponsors back up for closing comments. No? Thank you so much. We'll officially close the bill hearing on Senate Bill 424. Thank you so much for being here. Okay, members, thank you so much for your patience and your hard work today. At this time, we're going to move into work session. As a reminder, the speaker has waived the rules, given us permission to work session the bills that we have heard today. So we will we'll work session most of the bills that we heard, and we'll walk through that as we go. We're going to start today with a work session on Senate Bill 262, which revises provisions relating to graduate medical education. Mr. Flores.
Thank you, Madam Chair. Davis Florence, Committee Policy Analyst for the record. Just to summarize the amendment that was submitted by Senator Pazina to Senate Bill 262, this amendment makes a few additions to the bill. It adds language regarding approval of program changes for fellowships and other placements. It includes language for Medicaid support of programs, and it includes additional language on the awarding of grant funds. And thank you, Chair.
Thank you. Members, are there any questions on this measure? Seeing no questions, I will entertain a motion to amend and do pass. Motion by Vice Chair Nguyen. Second by Assemblymember Gonzalez. Is there any discussion on this motion? Seeing none, all those in favor say aye. Aye. Any opposed, nay. Motion carries unanimously. All of the floor statements I will assign to myself as a way just to help us move this along quickly. Thank you so much. That motion passes unanimously. The next item on our agenda is Senate Bill 192, which revises provisions relating to public health. Senator Neal just presented this bill to us, and we'll turn this over to Mr. Florence.
Thank you, Madam Chair. Davis Florence, Committee Policy Analyst for the record. The amendment that was briefly discussed by Senator Neal during the hearing proposes to remove sections 26 through section 26.95. Thank you, Chair.
Thank you. Members, any questions on this measure? Seeing no questions, I'll entertain a motion to amend and do pass. Motion by Vice Chair Nguyen, second by Assemblymember Gonzalez. Is there any discussion on this? All those in favor say aye. Aye. Any opposed, nay? Nay. If you'll raise your hands, please. Nays are Assemblymember Hafen, Assemblymember Hibbets, Assemblymember Edgeworth, Assemblymember Koenig, and Assemblymember Gray. Thank you. The motion does pass. Thank you. The next item on our agenda today is Senate Bill 54. This was one of the most recent bill presentations we just had. This bill requires Medicaid to provide coverage of certain services for persons experiencing homelessness. There are no amendments on this measure. Correct? Okay. Members, is there any discussion? Or any questions, rather? Seeing no questions, I'll entertain a motion to do pass. So moved. Motion by Vice Chair Nguyen, second by Assemblymember Hunt. Any discussion on this motion? Seeing none, all those in favor say aye. Aye. Any opposed, nay. Motion carries unanimously. Thank you so much. The next item on our agenda is Senate Bill 312, which enacts provisions relating to the health of American Indians. Members, is there any question on this measure? Seeing no questions, I'll entertain a motion to do pass. So moved. Motion by Vice Chair Nguyen. Second by Assemblymember Gray. Thank you. Any discussion on this motion? Seeing none, all those in favor say aye. Aye. Any opposed, nay. Motion carries unanimously. Thank you. The next item for work session today is Senate Bill 329, which requires certain persons to complete training relating to elderly persons and persons with cognitive impairments. Any questions on this measure? Seeing no questions, I'll entertain a motion to do pass. So moved. Motion by Vice Chair Nguyen, second by Assemblymember Hunt. Any discussion? Seeing no discussion, all those in favor say aye. Aye. Any opposed, nay. Motion carries unanimously. Thank you. Next up on our agenda today is Senate Bill 353 for work session, and this measure revises provisions relating to Medicaid. Are there any questions on this measure? Seeing no questions, I will entertain a motion to do pass. Motion by Vice Chair Nguyen, second by Assemblymember Gonzalez. Any discussion on this motion? Seeing no discussion, all those in favor say aye. Aye. Any opposed, nay. Motion carries unanimously. Next on our agenda is Senate Bill 424. This revises provisions relating to emergency medical services. Members, any questions? Seeing no questions, I will entertain a motion to do pass. Motion by Vice Chair Nguyen, second by Assemblymember Gonzalez. Is there any discussion? Assemblymember Koenig?
Yeah, I'm going to be a yes, but my phones are blowing up saying that.
If you will turn your microphone on, they'll get you on the recording.
Sorry about that. I was talking directly to you. Thank you, Chair. I'm going to vote this yes out of committee, but I've been receiving a lot of text messages here saying that we would be on the hook if the federal funds dry up. So I just want to resolve that in my mind before I commit to this vote.
Thank you. Assemblymember Edgeworth?
Similarly, I will be a yes to get this out of committee, but I'd like to clarify that point before I vote on the floor.
Thank you. Assemblymember Gray?
Ditto.
Anyone else? Ditto. I have a ditto from Assemblymember Hafen and a ditto from Assemblymember Hibbets. Thank you so much. Okay, with that, all those in favor say aye. Aye. Any opposed, nay. Motion carries. Thank you. And the next item is Senate Bill 497, which eliminates a requirement concerning rates of reimbursement under Medicaid for applied behavioral analysis. Any questions on this measure? Seeing no questions, I'll entertain a motion to do pass. Motion by Vice Chair Nguyen. Second by Assemblymember Dahlia. Thank you. Is there any discussion on this motion? Seeing no discussion, all those in favor say aye. Aye. Any opposed, nay. Motion carries unanimously. Thank you. That concludes our work session for today. Thank you. That moves us into the last item for today, which is public comment. If you would like to offer public comment, please come forward at this time. Seeing no public comment here in Carson City, none in Las Vegas. AVH, is there anyone on the telephone line who would like to offer public comment at this time?
If you would like to provide public comment, please press star 9 to take your place in the queue. Chair, we have no callers choosing to give public comment at this time.
Thank you, AVH. Thank you for everyone who is here with us today in Carson City and in Las Vegas, everyone on the telephone line. We have completed most of our work for this committee, but we are receiving additional bills this afternoon from what I understand. So look forward to another hearing on Friday, which is not yet agendized, but we do know that we probably will be meeting again on Friday. Thank you so much. This meeting is adjourned.